right sternal margin. Fourth intercostal space near the right sternal margin. Now, how do you identify the intercostal space? What you should do is, put your finger into the suprasternal notch, bring your finger down. The first bony prominence that you encounter is called the angle of Lewis, or the sternal angle, and that corresponds to the second rib. Right? The space below, the second space, third space, and fourth space. And that fourth space just adjacent to the right sternal border. Not the other. The right space is all the way from here to the back. So adjacent to the right sternal border will be your B1. B2 on the left side. Fourth intercostal space near the left sternal margin. B3, wait, don't do anything to B3 because it comes between B2 and B4. So what's midclavicular line? You know what is a suprasternal notch. You know what is acromioclavicular joint. You can feel the acromioclavicular joint. The midpoint is the midclavicular line if you drop a perpendicular downwards. So as the midclavicular line intersects with the fifth intercostal space, that's the place where you keep your V4. So the space between V2 and V4 is V3. V5, fifth is anterior axillary line. V6, fifth intercostal space, mid axillary line. What is anterior axillary line? You can feel the fold of the axilla. Up at the hand, you can feel the fold of the axilla, and that is the anterior axillary line. Mid axillary line, when you know the axilla, right in the middle, what will be mid axillary line. Now, if you don't pay attention to these anatomical landmarks, the ECG which you take is going to be erroneous. You can't interpret it. So this is something you will have to know. All people who are working in the emergency department, interns, sisters, nursing staff, whoever operates the ECG machine should get familiar with this. And these are anatomical landmarks. Tomorrow you may be taking an ECG, who knows, on the moon, right? You will be following. This is internationally accepted nomenclature. This is how an ECG paper looks like. This is a graph paper, basically. It has got some thick lines and thin lines. Each box has got 5 small squares horizontally and 5 small squares vertically. And if you look at the total duration, the ECG paper moves at a certain speed of 25 millimeters per second. Whenever the ECG paper moves, there is a speed at which it is a calibrated speed. It should move at a rate of 25 millimeters per second. So when it moves 25 millimeters per second, this box, right, it means it takes 0.2 seconds. And 0.2 seconds means each small box is 0.04 seconds. That is how you get to know. So why you need all this information? Because when you get a waveform, you need to calculate what is the P wave duration, what is the PR interval, what is the QRS, what is the ST segment, what is the duration of the P wave, all those things you need. And for that, the time measurement is through those boxes. Each small box is 0.04 seconds and one box is 0.2 seconds. Right? Now, it's also important to understand vertical part. The vertical part. I don't know how many of you are familiar. Olden days, before the ECG was taken, we used to press one button multiple times. And the stylus used to go up, down, up, down, up, down. And then we used to look at it and say, yeah, now I can do anything. Now what is that? Every time you press the button, you are giving a 1 millivolt current. So when you give 1 millivolt current to the ECG machine, the writer or the amplitude of excursion by the rating apparatus should be 10 millimeters. So this one box is 0.5 millimeters. So it should be 1 millivolt should be equal to 10 millimeters. Here it is 5 millimeters. 1, 2, 3, 4, 5. So So one large box is 0.5. But in your ECG machine, once you give 1 millivolt, the amplitude of movement vertically should be 10 millimeters. So, a standardized ECG machine means it is moving at a rate of 25 millimeters per second, the ECG paper horizontal. And the vertical deflection is for every 1 millivolt current, a deflection 10 millimeters. Is this clear? For every 1 millivolt current, the deflection should be 10 millimeters. And the writing speed should be such that the paper goes at a rate of 25 millimeters per second. And this is how a normal ECG looks like. It's a standard ECG, E1, E2, ER, and ER. The first three are bipolar leads, then the remaining all are unipolar leads. ADVERT is unipolar, mainly 1 to V6 unipolar ST. Now, one simple question. Can you read this ECG? You should not read this. Why you should not read this ECG? Because purposefully, I have not shown you the standardization. But then, if you look carefully, this is a computerized ECG. They read the standardization. Can you see one vertical bar? Between 1 and area, one line is there. That is standardized. It means that the standardization is appropriate. This is how a normal ECG looks like. You have the P wave, then you have the QRS complex, you have the S wave merging into the ST segment called the isoelectric ST line, the T wave and the U wave. I think I need to sort of point at there. Now I think it's better. So this is the P wave, the Q wave, the R wave, then S, and then comes the T, then comes the U. Please remember, these are positive waves. P wave, R wave are all positive. This is called the isoelectric line. Now what is the meaning of isoelectric line? Isoelectric line means there is electrical quiescence. That means no electrical activity in the heart here and here. That's why they are horizontal. There is no upward or downward deflection. And anything you measure as positive or negative is with respect to this isoelectrical line. Can you see it? So I will do it. So this is called the isoelectric line. So the P wave followed by a negative Q, a positive R, then the down part. After you see it, should stop here. This is the Q. This is the R. R stops here. This is negative, yes. Isoelectric. Positivity and a positivity. That's how you look at it. So it is with reference to this line. Again, P, electrical quiescence, negative Q, R, stop. Then there is a negative here, yes, isoelectric line, E, U. This is how you look at it. Now, why do you get these waves? The P wave is because of depolarization of the atria muscle is getting depolarized. Q, R, yes, this complex, the initial Q, positive R, negative yes. It's all because of depolarization of the ventricle. The T wave is because of repolarization of the ventricle. So depolarization of the atria, depolarization of the ventricle, repolarization of the ventricle. Something is missing here. Where is the depolarization of repolarization of atria is missing? This is depolarization of ventricle. this 2 belongs to ventricle. This is depolarization of atria. There is repolarization of atria. What happens to that wave? The repolarization of atria happens when this is happening. The QRS is happening. That is repolarization of the ventricle is happening. So, the repolarization of the atria, the wave that is produced, is hidden within the QRS complex. How do you know that? You know that when you do intracardiac electrogram. You know, you put some wires inside the heart and study the electrophysiology. You know, you do EP study, you call it as electrophysiological study. So when you do that, you will be able to identify the repolarization wave of the atria as well. You got my point? So, they may ask you, where is the repolarization of the atria? What would you say? The repolarization of the atria is hidden within the QRS complex. QRS complex represents the depolarization of the ventricle. Right. See, I told you one important thing, that the ECG paper moves at a rate of 25 millimeters per second. Right? So the graph comes. So you can know by graph how much is the duration of the P wave, what is the duration of the QRS wave, what is the duration of the T wave. You can know about it. Why? Because you know you got a paper which is going at a rate of 25 millimeters per second. So what you will do is, you will measure from here to here and say T wave has got maybe 3 boxes. 3 boxes means each box is 0.04 second. You know that, isn't it? I told you. One box means 0.04 second. So if this T wave transcribes 3 boxes, the duration of the P wave is 0.04 into 3. That is 0.12 seconds. So now you know the duration of the P wave. So if the patient has got atrial enlargement, left atrial enlargement or right atrial enlargement, something wrong will happen to the duration of the P wave. And so you can identify the chamber hypertrophy, left atrial enlargement or right atrial enlargement, which occurs by looking at the P wave morphology. See how useful the ECG is, isn't it? So, in the same way, you have got something called as QRS. Normally, if you begin from here and end up to here, the total duration of the QRS would not exceed 0.11 second. Normally, it's not exceeding 0.11 second. If it touches 0.12 second, it is already considered a bit abnormal. In the same way, you can measure something called as QT interval. Now, when I say QT interval, it's from the beginning of the Q to the ending of the T. It includes ventricular depolarization and repolarization. And normally, it is 0.36 to 0.44 seconds. Right? So, all those systems should be there. That's why looking at one way of the ECG. And that is why it's very important to spend time on the ECG. So you get the if you measure the heart rate, you can calculate the heart rate. Not only the heart rate, you can identify so many things on the ED. So for beginners, it's important that you have an important method. First of all, it's very look at the specialization of data. Once you get the specialization, you look at this is a clear, not heart rate, TIR, conduction. This is all about 2 hours, 2 hours, because systematically never be in a hurry to easy. You be systematic. Don't be easy. Don't be patient. So in the same way, don't be easy. So be very careful and it's not difficult. You have to spend time, you have to spend your energy on it. You have to sit with it. You have to count the number of squares. You have to do further analysis. Only when you do that, you are going to become proficient in CCP. So this is what is the standardization I mean. Explain this. I told you that CCP moves at 20 millimeters per second. And for every 1 millimeter, it is just 10 millimeters. So instead of saying 1 millimeter, I type it in every 9 millimeters. There should be a reflection of 10 millimeter. So this is how a standardization is like. This is how 1 millimeter per second. So what's the number of boxes here? 5. Let's start at 10. Can you see that? This CCD paper is a 25 millimeters per second, and somebody has given 1 millimeter analysis. So this slide like this, and the slide has got on 5 millimeters. Sometimes the working like this is so high, the heart can be 20 when the children are fulfilled. So the working is more, and when you are CCD, you are if you go into your paper, you won't know your days going. So you won't want to reduce the standardization. So what you do is, but every 1 millimeter say, I want to 5 millimeter differentiation or 0.5. What you use is what is half standardization. That is 5 millimeter. Sometimes when you do a CCC, especially women who are very obese, the QRS is so small. You will not be able to see the people fully, you will not be able to see the QRS fully, so you don't want to be far. So what you tell the relationship? It is standardization. But every millimeter that you express, they are to 20, not 10. So that is what process. Double standardization. So this is 20, right? But minimum 20. This is what double standardization. So do you know what this is the standard? All of the if you go there and you ask us to define what is CCP, this is how it is. This is data. So evaluate makes sense to you like that. Evaluate results about what the quality is for forward. Is the result real or not? Obviously, is there a period before and QRS? So there is a period behind and QRS. Are they a This is CCD, obviously state of it shows a period, a QRS, a period, a QRS, a period. So this is something related to the period, therefore it is a so you want this as a period together. No, but when you take the CCD, and there is a second hard yes. There is a simple rule of 300 or 1500 or technically it looks very difficult actually now. What are you doing is just solve the number of boxes between 2 to the number of boxes and divide by 6
Keep any one of them. Normally what I do is I remember this 1500. If you want, you remember it as 300. Whichever you feel comfortable. If it is 300, count the number of big boxes and divide. If it is 1500, there are the small boxes. Now for example, what is the rule of 300? See, there is a R wave here. There is a R wave here. How many big boxes? 1, 2, 3, 4, 5, 6. 300 by 6 is heart rate is 50 beats per minute. So if somebody gives you this ECG and says, tell me, what is the heart rate in this patient? Look at the ECG and tell me. You will say 50. Got it? What did you do? You counted the number of big squares. 1, 2, 3, 4, 5, and 6. So the heart rate is 50. Here, what is the heart rate? You can see one R wave here, one R wave here. How many boxes? 1, 2, 3, 4. If you count from here to here, that becomes one box. So 1, 2, 3 plus 1 box. So 304 is approximately 75. What is the heart rate here? Now look at this. This is ventricular tachycardia. VT. It doesn't show QRS. It just shows some broad complex QRS. Negative. And it is coming regularly. And if you look at the number of boxes between this and this, hardly 1.5 boxes from here to here. So divide 300 by 1.5, the rate is 200 beats per minute. Right? There is also something called as 10-second rule. That is, count the number of beats present on the ECG during 10 seconds, that is 50 beats squares, and multiply them by 6. For example, this ECG. So, from here to here, count the number of complexes. You have 33 complexes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 11, and then you come up to 33. And this you multiply by 6 and you get the rate as 198. So there are various ways of trying to calculate the heart rate. Now, normal ECG, this is something all of you are writing your exams, or all of you who want to understand about the ECG should know. No excuse. PR interval normal duration 0.1 to 0.2. So P wave duration should be not more than 120 milliseconds. So these are all these important points you have to know. You write it down somewhere, every day go and see, put it on your wardrobe, take a printout of this, put it somewhere. You have to know this. There is no excuse. And by repeatedly seeing the ECGs every day, you look at ECGs, you look at ECGs, try to calculate and see, is the PR interval okay for this ECG? Is the PR interval, take 5 ECGs, calculate PR interval. And then you will know, is it coming with 0.1 to 2.2 seconds. So here, the P wave duration should be less than 120. Now, what is this less than 120 milliseconds? What is this 120? 120 means 0.04. Each box is 0.04 seconds. So 3 boxes. 3 boxes will be 120. So the duration of the P wave in your ECG paper should not exceed 3 boxes. That's all. Is it difficult? Instead of remembering it as 120, best thing is look at the duration of the P wave, see if it is less than 3 boxes or more than 3 boxes. If it is more than 3 boxes, it's abnormal. Prolonged is less than 3 boxes is normal. That's all. PR interval. 0.1 to 0.2 seconds. 4 squares. What is 0.2 means 5 squares. 0.04 into 5 is 0.2. That's all. So see if it is less than 5 squares, 5 boxes. Isn't it? So it's all about application. How you apply your mind. So QR 120 milliseconds. So it should be 110, 0.004 plus 0.004 is 0.008 plus 0.004 is 0.1112. So it should be less than that. If it goes beyond that, you call it wide QRS. Simple. Isn't it? So QT interval also in the same way, you will diagnose interval also 440 milliseconds. It should be 440 milliseconds and less in males, 460 milliseconds and less in females. We'll come to that. So PR interval is atrial depolarization plus delay AV junction. That is AV node and one phase. So what is this PR interval? P wave you know is the atrial depolarization. Then until it joins the Q wave, there is a flat line, isoelectric line. What does the isoelectric line represent? It represents the current traveling through the AV node, which is electrically silent. So P wave atrial depolarization followed by that isoelectric line is called the PR interval. Now God has made it like this because you need time for the atria to contract before the ventricle starts contracting. Now what does it mean? It means, see, if you look at something called the cardiac cycle, if you look at something called the cardiac cycle, let's say it's about 0.8 seconds. How did you get that word 0.8? Did it fall from the sky? No. At a heart rate of 70 per minute, if you divide it by 60, it comes as 0.8. So for a heart rate of 72 per minute, each cardiac cycle is, that is one atrial systole and one ventricular systole is 0.8 seconds. That's how you got 0.8. It didn't fall from the sky. What if the heart rate is 60 per minute? What will be the cardiac cycle? It's not 0.8, it will be 160 by 60. You got my point. So 0.8 seconds is the duration of the cardiac cycle when your heart rate is 72 beats per minute. For a heart rate of 60 beats per minute, it's one second cardiac cycle. Forget it. Okay. Now you understood how I got this number 0.8. Now this 0.8, atrial systole is 0.1 second, atrial diastole is 0.7 seconds. Ventricular systole is 0.3 seconds, ventricular diastole is 0.5 seconds. So look at this, atrial is a lazy fellow. Atria contracts only 0.1 and sleeps for 0.7. Ventricle contracts for 0.3 and diastole sleeps for only 0.5. But atria is a lazy fellow, contracts 0.1 and sleeps off. But look at God's creation. Where is the atrial systole timed? The atrial systole overlaps the last part of ventricular diastole. You know, the ventricle is fully filled. Then the atria contracts the last part. And it empties all its blood into an already filled left ventricle or right ventricle. And it stretches that ventricle further. And you know that the force of contraction of a muscle fiber is directly proportional to the initial length of the muscle fiber within physiological limits. That is Starling's law. So when the atrial contraction is in the last and the atria has completely emptied its blood into the ventricle is overstretched so that the next contraction contracts powerfully according to Starling's law. That's why, though the atria is a lazy fellow, he works for that 0.1 second. It's enough to contribute to, my friends, 30 to 40% of your cardiac output. That is the importance of the atrial contribution to ventricular filling. Atria acts like a booster pump mechanism. Got my point? So the PR interval includes this atrial depolarization and that little time is given to flow to the atrioventricular node so that the ventricle is filled with the atrial blood. That is the importance of this PR interval. Normal PR interval is, remember, 0.1 to 0.2. That is 3 to 5 small squares. If you get a short PR interval, there's something called Wolff-Parkinson White syndrome. Long PR interval, it's a first degree AV talk. What is this Wolff-Parkinson White syndrome? WPW syndrome means, normally from the SA node, the impulse should come to the AV node via interatrial tract. Sometimes it so happens that this AV node is bypassed by some tracts called atrioventricular tracts. And instead of the current going through the AV node and depolarizing the ventricle, it will go through these accessory pathways and depolarize the ventricle. When you have this accessory pathways, paraseptal, anterior septal, posterior septal, all these kinds of pathways, you call it WPW syndrome. You identify this 3D mapping on an electrophysiological study and update them to prevent tachycardia. Anyway, that's for a different day. Now long PR interval is first degree AV block. Right. So this is how the first degree AV block looks. Long PR interval. This is the short PR interval. See how the distance between PR is very short. Yeah. So this is again a repetition. Normally QR duration should not be more than 110 millisecond. So if it goes beyond 110 millisecond, you get something called as bundle branch blocks. Now this is how normally it should be. Now look at what has happened. In lead V1 and V6, these are two leads to identify, to understand what is lead, bundle branch block. See this? This is prolonged. If you look at the duration from here to here, it is prolonged. And from here to here, it is prolonged. So if it is predominantly like this, R, S, R dash, in V1, positive, negative in V1. If it is positive, it is right bundle. It is negative, it is left bundle. Opposite to V6. Right? See that? M shape will be in V1. Right bundle. M shape in V6 will be left bundle. Right? I know. You should go back and read. You just listen to my lecture. Enough. Go back. You see right bundle block. You see left bundle block. Then you will get to know what it is. So this is right bundle branch block. This is left branch block. Why? You can see V1 negative and V6 will be positive. See that? Negative here, positive here, wide QRS in V6. This is QT interval. So QT interval is from the beginning of the Q to the ending of the T. It represents depolarization of the ventricle and repolarization of the ventricle. So this band is called QT interval. QT interval is depending upon the heart rate. So normally we give some correction for the heart rate, and that is called by a formula called Bezet's formula. Now Bezet's formula is this. Corrected QT is QT interval divided by square of RR interval. Like I told you, it should be 440 for males, less than 460 for females, less than. So there's one more formula. Don't worry too much about this. So prolonged QTC, these are the conditions where you get prolonged QTC. Sleep, hypocalcemia, myocarditis, myocardial injury, drugs, hypothermia, hypertrophic obstructive cardiomyopathy. Prolonged QTC, you can get it in AV block, high degree AV block, Jervell-Lange syndrome, Romanov syndrome. These are called congenital QTC interval syndromes. Sometimes you can get a short QT. Digitalis, hypercalcemia, hyperthermia, and vagal stimulation. Now comes the QRS axis. I think there are two ways of trying to find out the QRS axis. Remember, the heart is here. So the normal electrical axis is directed downward and inferiorly and posteriorly. Right? So this is how normal axis is. And when you plot a normal axis, it is from minus 30 to plus 90. If it is from plus 90 to plus 180, it is called right axis. If it is from minus 30 to minus 90, it is called left anterior. Left axis deviation. And if it is not anywhere beyond this, it is called intermediate axis or undetermined axis. So this is how the QRS axis is determined. I know this is not going to be easy. You have to sit down, spend your time. I think I'm given very less time to explain on this. Started late, but given less time, but let me see what I can do. I'll tell you an easy method. One is to take a graph paper and plot it. And if you plot like what you need to do by plotting is take a graph paper, take lead one. See how many positive squares are there for the R wave. Positive, negative, and finally, like an engineering student, you have to plot it and get your QRS axis. Other easy way is the quadrant approach or the equiphasic approach. You know if it is QRS is positive, negative, some leads it's called equiphasic. Equiphasic means half positive, half negative. That's how it's going to be. Right. If the lead one is positive, lead AVF is positive, normal. Lead one negative, lead AVF positive, right axis. Lead AVF negative, lead one positive, left axis. Lead AVF negative, lead one negative, it is indeterminate axis. Can't have plotting of the axis all. So here you can see negative in lead one. Positive in AVF. That is AVF plus 1. So it is right axis. This is positive in one, negative in AVF. So it's got to be left axis. Sorry, I'm not able to spend too much of time explaining. This is how it is. I think all of you should go back, open your books and read. What's the quadrant approach? Equiphasic approach is something very easy. You know what we do in equiphasic approach is we take the most equiphasic lead. Now see lead one positive. This is negative. We don't want these two leads. See this is half positive, half negative. Which lead is this? Lead 2. RA to left leg. So if you take lead 2, take a perpendicular to that. Now if AVF is this and lead 2 is this will be the perpendicular, isn't it? So it will be minus 30. So a perpendicular to the most equiphasic lead will be the axis. Another example. Here again you can see equiphasic in lead 1. Positive, negative, almost equal. So if this is equiphasic, it's got to be 90 degrees. So axis is plus 9. So this is the equiphasic approach. So P wave, heat rate depolarization, QRS ventricular depolarization, E wave is ventricular depolarization. I told you about the P wave. It's seen most of the time in lead 1, lead 2, V1. It should be not more than 2.5 millimeters in amplitude, not more than 3 boxes in terms of its duration. So if you have an atrial abnormality, you get a right atrial enlargement with tall P waves. And it's called P pulmonale. This is what it is. Can you see this? This is tall P waves. This is not supposed to be so tall. This is called P pulmonale. This is P mitrae. This you see in mitral stenosis. You can see a negative deflection which is occupying more than one box. This is called P mitrae. This is considered to be left atrial enlargement. So this is how you diagnose left atrial enlargement. This is how a normal QRS axis looks like. Lead 1 and lead 6. And when you look at the QRS, to identify a small positive deflection lead 1, that's called the septal R wave. Normally there's interventricular septum and it conducts from left to right. Right? So you can always see positive deflection in the right lead, the V1. And you have a septal Q wave opposite of that's happening in the V6. So this is about the various URS complexes, and you look at something called as the R-wave progression. Normally, there is something called as a transition zone. If it grows, the R-waves, it grows to a point where this becomes equal. Normally, the transition zone is either in V3 or V4. So if the transition zone shifts, indicates either it's left ventricular hypertrophy or right ventricular hypertrophy. Now left ventricular hypertrophy means predominant left ventricle. So you get all R waves in V6. And when you add the R wave amplitude in V5 and the S wave amplitude in V1 and you add them together, if it is more than 35, it tells you that it is left ventricular hypertrophy. This is called Sokolow's criteria. There are so many criteria for diagnosing chamber hypertrophy, of which one of them is Sokolow's criteria. If the height of the R wave AVL is more than 11 millimeters and 8 millimeters in women, it's another criteria to call that there is left ventricular hypertrophy. So right ventricular hypertrophy is again QR in V1 branch block. T-wave inversion in the anterior leads. So many criteria. Once you start looking at ECGs of congenital heart diseases or ECGs of pulmonary embolism, you will get to know what is right hypertrophy. So these are all ST segment elevations which happen. So this is what? This is something all of you should know. ST elevation. Convex. Look at that. This is supposed to be the isoelectric line. So where it is? Come right up here. So that is ST elevation. So these are all the T waves. Sometimes T waves are looking like this. U waves sometimes you see small U waves come after the T waves. Maybe physiological. Now I'll just take you through some disease conditions. This is the normal anatomy, right? Coronary artery and left coronary artery. When you get a heart attack, if you look at the ECG, it can reflect the type of heart attack. Either anterior wall MI, posterior wall MI, inferior lateral MI. So depending upon certain characteristics, you can identify where the MI is. So this is how the ST segment is. It is normal. Here it is elevated. Here it is depressed. Now how do you know it is elevated? How do you know this is depressed? It is respect to isoelectric line. If you draw a line here, you know it is considered to be isoelectric. Here it is depressed. Right. So this is something called as the J point. This junction between the ST segment and the S wave is called the J point. If this goes up, it's called ST segment elevation. So it can be code or it can be convex upwards. So this is how it looks like. See here. This is supposed to be the isoelectric point, ST segment elevation. This is supposed to be the isoelectric point, ST segment depression elevation. So if you get ST elevation V1 and V2, it's a septal MI. V3, V4, it's an anterior MI. 1 AVL, V5, V6, it's a lateral MI. And if it is 2, 3, and AVF, it's an inferior wall MI. So this is how you anatomically group the MIs. 1 AVL, V5, V6, lateral. V3, V4, anterior. V1, V2, septal. 2, 3 AVF, inferior wall MI. So you should look for these ST segment elevation in these corresponding leads to categorize the patient having inferior wall MI, anterior wall MI, anteroseptal MI, lateral MI. What MI is this? V1, V2, V3, V4, V5, V6. It's an extensive anterior wall MI. It's involving even one end AVL. So it's extensive anterior MI, anterior, septal, lateral, everything is involved. Look at that. This is what? 1 AVL, V5, V6, ST elevation. So this is lateral MI, anterior MI. V1, lead 1, is okay. Depression. Lead 2, ST elevation. Lead 3, ST elevation. AVF, ST elevation. So what MI is this? Inferior wall MI. So there are a lot of drugs also which cause the problems. Hyperkalemia. This is what it does. You can see widening of the QRS. You can see tall 10 P waves in this. And this is finally what happens. Patient goes into bradycardia and you get sinusoidal P waves. Then he may go into complete heart block. So hypokalemia, hypercalcemia, digitalis, they are all that they affect the ECG. So when you look at bradyarrhythmias, you have sinus bradycardia, junctional rhythm, sinoatrial block, atrial block. Now this is sinus bradycardia. All complexes are okay, but if you look at the heart rate, 1, 2, 3, 4, 5, 6. So it means the heart rate of 50 per minute. That is less than 60 per minute, but regular. Every wave before QRS. PR interval is normal, so it's a sinus bradycardia. Here you see that the heart rate is between 40 to 60. It's a junctional rhythm, and the P wave is absent here. Sometimes they may follow the QRS complex also. Sinoatrial block. Suddenly there's no P wave coming here at all. This is sixth sinus syndrome. Yeah. No P wave at all. AV block can be first degree, second degree, third degree. In first degree block, you just get prolongation of the PR interval. That's everything else there. Normal. So if there is prolongation of the PR interval, it is called first degree AV block. Normal PR interval is 0.1 to 2.2. Anything more than 0.2 is abnormal. It's called first degree AV block. Second degree AV block, this is how it looks. See here what is happening in second degree AV block. This is the PR interval, becomes prolonged, P comes, no QRS. So PR goes on becoming prolonged. As the PR goes on getting prolonged, it followed by a drop in the QRS. That is called as back phenomena, or it's called Mobitz type block. In Mobitz type block, there is one P wave which doesn't get conducted at all. But the PR interval doesn't vary. There is no successive prolongation of the PR interval. The PR is varied. It is varying. With the PR. The QRS doesn't come. One P wave doesn't get conducted. That is called as Mobitz type block. This is called twist one block. Mobitz type block. And third degree block, there is no relationship at all between the P wave and the QRS. Look at this here. Look at this P. There is no relationship at all. Isn't it? The P waves fall where they want. The QRS waves, they come they want. But there is a fixed relationship between RR, a fixed relationship between PP. But the PR do not relate to that. This is called AV dissociation or complete heart block. So arrhythmia formation, sinus atrial AV junction. These are all things. These are all quiz, I think. How you should be looking at. If there are good waves, the PR interval is normal, QRS duration is normal, it's sinus bradycardia. Here the rate is more. P wave is normal, PR interval is normal, QRS duration is normal, everything is normal. But the rate is more, so it is sinus tachycardia. Now if somebody asks you what is a normal heart rate, you should always say it is 61 to 99. 60 and below is bradycardia. 100 above is tachycardia. Please remember this. Heart rate is never one fixed number. 61 to 99 is the normal heart rate. The moment touches 100 and above is tachycardia. The moment touches 60 and below is bradycardia. You should have a clear mathematical conception about the heart rate. So these are premature atrial contraction, nothing much about it. See this P wave, they are different. So the QRS is narrow, it's not wide. So it's a premature atrial contraction. This B should have come, next should have come here. It has come early. So see the distance between this, but this has come early. So it is premature. And abnormal P wave, narrow QRS. So it's premature atrial contraction. So Supraventricular arrhythmias can be atrial fibrillation, supraventricular tachycardia. So this is the typical sawtooth appearance. So this is atrial flutter. Right. This is paroxysmal supraventricular tachycardia. See, this was all normal. See, suddenly what happened? Can you see the change? This is normal. From here on, see the rate. It is supraventricular tachycardia. Runs of supraventricular ectopics, but are all narrow QRS. Right. This is very abnormal looking beat, and this is a ventricular premature contraction or premature ventricular contraction. I'm sure all of us are very good at picking this up. So this is ventricular tachycardia. There's so many ways of diagnosing ventricular tachycardia. Ventricular tachycardia kills if you don't take action, isn't it? VT needs to be cardioverted electrically if it is hemodynamically significant, or pharmacologically if you have the time. So this is one lead. This is called Wernicke algorithm. By looking at one lead, AVR, if you have a dominant R, it's a VT. If you have an initial Q, which is more than 40 milliseconds, it's a VT. If there is a notch downstroke of the QRS, it's a VT. And if you have voltage delta in the last 40 milliseconds, it is VT. So one lead can identify VT. This is ventricular fibrillation. This is most of the time terminal rhythm. Ventricular fibrillation, no questions asked. Forced ventricular fibrillation has to be what? Electrically cardioverted, isn't it? So the last 10 slides, Professor Chamberlain's 10 rules. Rule 1, PR interval should be 120 to 200 or 3 to 5 squares. Rule 2, width of QRS complex should not exceed 110. Rule 3, QRS complex should be dominantly upright in V1 and AVF. Rule 4, QRS and T waves tend to have the same general direction in the limb leads. Rule 5, all waves are negative in lead AVR. All waves are negative in lead AVR. If AVR is positive, it means what? Right ventricular hypertrophy. Rule 6, R wave must grow from V1 to V4. Yes, wave must grow from V1 to at least V3 and disappear in V6. Yes, wave should not be seen in V6. But all you see should be small, maybe 1 millimeter, 2 millimeter, not more than that. Rule 7, ST segment should always be isoelectric. Rule 8, P wave should be upright in 1, 2 and V2 to V6. There should be no Q waves or only small Q of less than 0.04 seconds or less than 25% of R wave in 1, 2, V2 to V6. Otherwise, these waves will not be called physiological. They will be called pathological Q waves. Pathological Q waves means MI, old MI, necrotic tissue. T wave must be upright. V2 to V6. Thank you for your patience. And I know it's been a presentation, but given the thank you for your patience. Any questions, any time? I'm always. Thank you.
Hello. Thank you so much, sir. We request all the dignitaries to please stay in the platform because in our upcoming session, sir will be providing you goodies for all the attendees. Next we have food care for everyone and everywhere by Dr. Sunil Curry from Mandakini Hospital, Hubballi. Please give a huge round of applause as we welcome sir on stage. Sunil Vasudev Curry, Senior Consultant Diabetic Surgeon, Head and Department of Diabetic Limb Salvage, Chief of Diabetic Salvage Team. And he's been a member of Indian Medical Association and also the Association of Surgeons of India. He's also an academic member of RSSDI Delhi, KRSSDI Karnataka, Asia Pacific Diabetic Limb Problem Association Singapore. He has given various lectures and we are huge honor for us to have sir in our occasion today.
Well, good morning. Indeed a pleasure. There's something unique where I could see a small, really interested group in food care sitting right in front of me. And I think the rest of the show, they should understand it. So I think I have to take it in Kannada also. Because they are, as a paramedic staff sitting in the last few rows, ಅವ್ರಿಗೆ ಗೊತ್ತಾಗಲೇಬೇಕು. ನೀವೇನು ಲಾಸ್ಟ್ ನೀವೆಲ್ಲರೂ ನೋಡ್ತೀರಿ, ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡ್ತೀರಿ, ಗೊತ್ತಾಗಲೇಬೇಕು. ಅದನ್ನೇ ನಾನು ಹೇಳಿ ಬಂದಿದ್ದೇನೆ. ಎದುರುಗಡೆ ಟಾಪ್ ಪ್ರಯಾರಿಟಿ ಸೀನಿಯರ್ ಮೋಸ್ಟ್ ಇದ್ದಾರೆ, ಅವ್ರಿಗೆ ಬಹಳಷ್ಟು ಹೇಳೋದಿಲ್ಲ ನಾನು. ಆದರೆ ಕ್ಲಿನಿಕಲ್ ಟಿಪ್ಸ್ how a food behaves in diabetes. What exactly I should do on Monday when I start practicing in my clinic. That is important. I'm not going to show you any kind of literature, any research, nothing. I'm going to give you a clinical tips right in front of you. There are three tables. I'm going to show you what is importance of a footwear science, what is importance of exercise science, how I can heal an ulcer in the foot in my clinic. That is my prayer. That is what I have been doing past 25 plus years in Hubli. I don't see anything above groin. I have been seeing only limbs and lower limbs. I have brought this figure. You're all very fascinated to know. You're all fascinated to know the color. The red is artery, the blue is vein. No, I'm more interested. You check the footprints. I want all those doctors sitting in front of me should see that those two footprints should be maintained throughout of all the diabetics. ಪ್ರತಿ ಡಯಾಬಿಟಿಕ್ ವ್ಯಕ್ತಿಯ ಆ ಎರಡು ಬಲಗಾಲು ಎಡಗಾಲು ಪ್ರಿಂಟ್ ಯಾವಾಗಲೂ ಕಾಣಲೇಬೇಕು. That is what is care. If somebody is using little toe, great toe, that means we have not done a proper job in our workup. I will ask you a simple request. I'm going to. How many doctors are here in this hall? Please stand up. How many doctors are there? Please stand up. I request you to one second stand up. Look at it. How important limb is. How important it is holding your weight. It is so difficult in diabetes to operate on this limb and hold this weight. No organ in the body takes the body weight. Heart doesn't take body weight. Brain doesn't take body weight. Please sit down. My staff will give you a special kit. I think where is my staff? Just doctor's kit kodama. I'm going to demonstrate you why that kit is important. How I have designed it. How I have learned last 25 years. How I should reach to my colleagues. Very important. Every item in that kit is so important. It is having a binding with a doctor and a binding with the patient. I want you to understand that. What is there in that kit? Only doctor should have that kit. Paramedic staff There is a very straightforward two photographs are there on that bag. In the kit melody, front bag ನಲ್ಲಿ save the link to prolong the quality of life. ಪ್ರತಿ diabetically ನೀವು quality life ಕೊಡ್ಲಿಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡಿ. There are so many things written here. Ulcer, infection, gangrene, varicose ulcer, there is a block. So many things are there. This is what a unit. We have a comprehensive food care. What is comprehensive care? I will show you. My son has joined me, Dr. Shashank, who is ex endovascular and open. He is a vascular surgeon where he has a big difference last year where we are working on every segment of vascular work. This is what I am here with you to empower the healthcare worker in the rural segment. I'm not looking at metro segment. I'm looking at rural segment. Where I don't want any doctor to refer me any patient. This is how preventing the first ulcer in diabetes is very important. I don't want any artificial Jaipur foot also to my rural patient. Jaipur foot ಗೆ 2,000 ಸರ್ ಬೇಡ ನಮಗೆ. ನಮ್ಮ ಹಳ್ಳಿ ಜನಗೆ ಅದು ಜೈಪುರ್ ಫುಡ್ ಬೇಡ. ಹಾಗೆ ನಾನು ಪ್ರಿವೆಂಟ್ ಮಾಡ್ತೀನಿ. I want an Indian rural diabetic forward to avoid Jaipur film. That should be the motto of every person who is sitting in this hall. ಎಲ್ಲರಿಗೂ ಬರ್ತದೆ heart attack. ಈಗ just ಮಾತಾಡಿದ್ರು ಸರ್. He showed you number of ECGs. Thak. Ambulance ಊರಲ್ಲಿ ಎಲ್ಲ heart attack. ಯಾರಿಗೂ foot attack ಅಂದ್ರೆ ಗೊತ್ತಿಲ್ಲ. There is a big issue on foot attack. ಯಾವುದು ಮೊಳೆ, any penetrating injury. If patient can sir ನಾನು ಮುಳಿತಿರಿ, that is foot attack. The infection has reached from the plantar skin to directly to the metatarsal compartment. You can't waste time there. It has to be emergency treatment. Please understand foot attack. How we can reach? You can reach through so many ways now. Immediately needs care. What is the outcome of early work and early reference? Look at it. Day 100. Every wound heals in 100 days. Every week there is 10% reduction in the size. What are the pillars? Metabolic correction, vascular correction, microbiology, wound education. And the most important is late reference end up such kind of workup. Patient ಹೇಳ್ತಾರೆ ಸರ್ ನೀವು ಕಾಲ್ ಮೇಲೆ ನಡಿಬೇಡ ಅಂತ ಹೇಳಿರ್ತೀರಿ. ಕಾಲ್ ಮೇಲೆ ನಡಿಬೇಡ ಅಂತ ಹೇಳ್ತೀರಿ. ನಾವು ಹೆಂಗ್ ನಡಿಬೇಕು? ಹಾಗಿದ್ರೆ ಕೈ ಮೇಲೆ ನಡಿಬೇಕು patient ಅನ್ನ. So if we don't off the foot, the well which is having wound, you have reduce the body weight. Then only the patient can walk on his foot. And that is a science. ಇದು ನಿಮ್ಮ ಬ್ಯಾಗಿನಾಗದ ನೋಡ್ರಿ. You can open and see that bag. ಒಂದು ಚಾರ್ಟ್ ಕೊಟ್ಟೆ ನಾನು ನಿಮಗೆ. ಎಲ್ಲರೂ ಸಣ್ಣಾಗಿರ್ತಾರೆ. ಈ ಚಾರ್ಟ್ ಹೊರಗೆ ನಿಮ್ಮ ವೇಟಿಂಗ್ ರೂಮ್ನಾಗ ಇಡಬೇಕು. ಪೇಷಂಟ್ ಹೇಳ್ಬೇಕು. ಸ್ನೇಕ್ಸ್ ಅಂಡ್ ಲ್ಯಾಡರ್ ನಮಗೆ ಲ್ಯಾಡರ್ ಬೇಡ. ಸ್ನೇಕ್ ನೋಡ್ರಿ. ಏನೇನು ಸ್ನೇಕ್ಸ್ ಅದಾವ? ಮೆಟಬಾಲಿಕ್. ನೀ ಸಕ್ರಿ ಕಂಟ್ರೋಲ್ ಮಾಡಿಲ್ಲ ಅಲ್ಲಿ ತೊಂದರೆ ಆಗ್ತದೆ. ಒಂದು ಸ್ನೇಕ್ ಅಲ್ಲೇ ಕೂತಾನ. ಎಜುಕೇಶನ್ ಸರಿಯಾಗಿ ಕಾಳಜಿ ಮಾಡು. ಎಜುಕೇಶನ್ ಮಾಡಲಿಲ್ಲ ಎರಡನೇ ಲೆವೆಲ್ಗೆ ಝೀರೋ ಕುಂದಿರ್ತೀರಿ. ಥರ್ಡ್ ಲೆವೆಲ್ ಆಫ್ಲೋಡಿಂಗ್. ಗಾಯ ಆಗಿದೆ ಆಫ್ಲೋಡ್. ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಇನ್ನೊಂದು ಸ್ನೇಕ್ ಪ್ರಾಪರ್ ವುಂಡ್ ಕೇರ್ ಎಲ್ಲ ಮಾಡ್ಲಿಕ್ಕೆ ರಕ್ತ ಬರಕತ್ತಿಲ್ಲ. vascular care. Then there is a big snake sitting there. You can't reach to the 100. And education, microbiology, first culture model hoy. You have to have tissue and bone culture, which are very specific. You can't shoot antibiotics randomly. Very important. Now you have got one more thing. ಇದು ಒಂದು ಕಾರ್ಡ್ ಕೊಟ್ಟಿದ್ದು ನೋಡಿ. ನೀವೆಲ್ಲ ಪೇಷಂಟ್ ನೋಡ್ತಿರ್ತಾರ ಅವ್ರು. ಬೇರೆ ಕಾಲಲ್ಲಿ ಆಗಿದಾವ. If somebody comes to you, ನಾ ಏನ್ ಮಾಡ್ಬೇಕು? ಕ್ಲಿನಿಕ್ ನಲ್ಲಿ ಮಂಡೇ ಏನ್ ಮಾಡ್ಬೇಕು? ಫಸ್ಟ್ ಸ್ಟ್ರಾಟಿಫೈ ಮಾಡಿ. Is it a low risk? Is it a medium risk? Is it a high risk? Please work on this criteria. Sir, ನನ್ನ ಸಕ್ಕರೆ ಕಂಟ್ರೋಲ್ ಇದ್ರಿ ಕಾಲಿಗೆ ತೊಂದರೆ ಇಲ್ಲ. Still you have to walk zero. He has to attend you every year. Every year he has to come for a foot checkup. Please stratify every patient for the foot. In what stage he is. ಇದೊಂದು very interesting diabetic protection ಮಂತ್ರ patient ಓದಂಗೆ ಹೇಳೋ. ಮಂತ್ರ ಓದ್ತೀನಿ ಸರ್ ಅಂತ. I have given you two mantras. ಅದನ್ನ ನೀವು ವೇಟಿಂಗ್ ಹಾಲ್ ಇಟ್ಬಿಟ್ರೆ ಎಲ್ಲರೂ ಓದ್ಕೊಂಡು ಬರಬೇಕು. ಕ್ವಶ್ಚನ್ ಕೇಳಬೇಕು ನೀವು. ಸರ್ ಇದೇನ್ರಿ ಇದು ಏನೋ ಬರ್ದಿರೋ ಏನು ಕಾಲಿನ ನೋಡ್ತೀರಿ ನನ್ನ ಕಾಲಿಗೆ ಜಾರ್ಲಿಕ್ಕೆ ಗುರುತಾಗೋಲ್ತು. That itself is a neuropathy. If it tells you something that is neuropathy. Try to understand this science. ಒಂದು nail file ಕೊಟ್ಟೆ ನಾನು ನಿಮಗೆ. I have given you nail file you can see. Please make it a point. Nail thick ಆಗಿರ್ತಾವ diabetes ನಾಗೆ. ಕಟ್ ಮಾಡಬೇಡಿ. ಫೈಲ್ ಮಾಡಿ ಸರಿಯಾಗಿ ಫೈಲ್ ಇಟ್. ಪೇಷಂಟ್ ಎಜುಕೇಟ್ ಮಾಡಿ. nail ಕಟ್ ಮಾಡಿ ಅಲ್ಲಿ ಗಾಯ ಮಾಡಿ ಅದೇ ದೊಡ್ಡ ಗ್ಯಾಂಗ್ರೀನ್ ಆಗಿರ್ತದೆ. So always make it a point. Doctor should have a nail file to show to him. ಇದು ಹೋಗಿ ಮಾರ್ಕೆಟ್ ನಾಗಿಂದ ತಗೊಳ್ಳುವ. The doctors who are sitting in this hall should know what is my CPR score to save the limb. I have to check which is a priority. Every foot has to be checked. ಅದಕ್ಕೆ ನಾನು ಕೊಡೋದು ಕೇವಲ 2 ಮಾರ್ಕ್ಸ್. I am going to protect. ಅದನ್ನು ಕಾಳಜಿ ಮಾಡ್ತೀನಿ. ಅದಕ್ಕೆ 3 ಮಾರ್ಕ್ಸ್ ಕೊಡ್ತೀನಿ. I don't know. ನನಗೇನು ಮಾಹಿತಿ ಇಲ್ಲ. Please refer. If you don't know anything, don't keep it with you. Refer it to the higher center. ಅದಕ್ಕೆ 5 ಮಾರ್ಕ್ಸ್ ಕೊಡ್ತೀನಿ. So you want to win this game, you should have 10 out of 10 in a right way in your day-to-day practice. You can't just see that ನಾ ಮಾಡ್ತೀನಿ ಆರಾಮ ಮಾಡ್ತೀನಿ. No. The delay in reference has led to maximum mortality. Look at it. In few seconds, we were planning to host whatever the figure you are seeing there. I have promised Malan sir that I want to see that 54 feet height crutch. I want to design this next hall. He had given space, and we had requested all the authorities in the world record. They were unable to reach us, so we couldn't do that. But definitely we will do it in some time. And this is how they are losing the diabetes. Highest. They are losing maximum. Every second one is lost due to diabetes somewhere in some part of the world. ಈಗ ನನಗೆ 2 ತಾಸು ಕೊಟ್ಟಾರೆ. 60 ನಿಮಿಷನಾಗ ನೀವು ಏನಿಲ್ಲ ಅಂದ್ರೂ 180 ಕಾಲ ಅಂತ ಅಂದ್ರೆ 360 ನಮ್ಮ ಸುತ್ತಕ. So look at how the speed. Somebody has to stop this watch. We have to work on this area. We need to be more clinical. The inertia has to go. The physicians are having a lot of inertia. Surgeons, I don't have any job. If you prevent the first ulcer in the foot, I don't have any job. I can change. I can go to different work. This is what is very important. We need to prevent amputations. Now, there is one calendar I have given you, 2026. Please open and see that calendar. And that calendar will boost your inspiration. How I can save the limb in diabetes. The first page of the calendar says from soul to shoe, our foot is unmatched. The calendar will definitely tell you the first January. Before, after. The 4 foot ulcer has healed. ಅಂದ್ರೆ ನಾ ಗಾಯನ್ನು ಮಾಯಿಸಬಹುದು. ಆಯ್ತು. ಹಿಂಬಡಿದ ಗಾಯನ ಕೂಡ ಮಾಯಿಸಬಹುದು. ಆನೆ ಕಾಲು ಸರಿ ಮಾಡಬಹುದು. Elephant ears can also be treated well. Blocks can also be treated. ಹೇಗೆ how it should be with guideline with international working guidelines ಅದಕ್ಕೆ. I have given you comprehensive foot care. Simple steps. You have to have neuropathy assessment, vascular assessment, footwear assessment, pressure assessment, and wound care assessment. ಎಲ್ಲರೂ ಕೇಳ್ತಾರೆ ಯಾವುದು ಚೆನ್ನಾಗಿ ಸರ್, ನನಗೆ ಟೈಮ್ ಇರೋದಿಲ್ಲ ಸರ್, ಪೇಷಂಟ್ ಇರ್ತಾರೆ ನಮ್ದು ಮಿನಿಮಮ್ ಮ್ಯಾಕ್ಸಿಮಮ್ ಒಪ್ಪಿಡಿ ಸರ್, 120 130 ಹೇಗೆ ಮಾಡಲಿ ಅಂದ್ರೆ PNPSS ನಿಮಗೆಲ್ಲ ಐ ವಿಲ್ ಶೋ ಯು ನೌ ವಾಟ್ ಶುಡ್ ಬಿ ಡನ್. One of my patient will lie there. What is a quick assessment when the foot is going to break? This is thing you should follow. This is the guideline. You need not take any photographs. It is there right in calendar. It has to be on your table. Daily practice. You should keep it on your table. And you should see those calendars. This is how you have to follow the stepwise pattern. Next. What footwear I have to buy? ಯಾವಾಗ ತಗೋಬೇಕು ಚಪ್ಪಲನ್ನು? I have brought you all the footwears here. ಸರ್ ಯಾವಾಗ ಖರೀದಿ ಮಾಡಬೇಕು ನಾನು? ಆಮೇಲೆ ಇದರ ಆಯುಷ್ಯ ಎಷ್ಟು? The man who is having neuropathy, diabetes, ಆ ಚಪ್ಪಲಿಯ ಆಯುಷ್ಯ ಕೇವಲ 3 ರಿಂದ 4 ತಿಂಗಳ ಮಾತ್ರ. Only 3 to 4 months. Not more than that. ನಮ್ಮ ಇಂಡಿಯಾನ ಹರಿಯುತ್ತಿನ ಚಪ್ಪಲಿನಿಂದ ಅದು ಹರಿದು ನಮ್ಮ ಕಡೆ ಬಂದಿ. So please make these points very clear. If a diabetic is there, check is insole and top. And insole, if it is 9 mm, it is ideal. If it reduces by 50%, sir, chalo itri. Go on. ಅವನಿಗೆ ಅಲ್ಸರ್ ಆಗಿಬಿಡ್ತದಲ್ಲ. ಆ ಚಪ್ಪಲಿ 100%. Everyone sitting in this hall, especially IMA, GPs, which I request, general practice, healthcare workers, patients, ಯಾಕೆ ಓಡಿಲ್ಲ ಜಿಗಿದಿಲ್ಲ exercise ಮಾಡಿಲ್ಲ. You keep on shouting at him. ಬರೀ ತಿನ್ನಕತ್ತೀರಿ ನೀವು, exercise ಮಾಡಕತ್ತಿಲ್ಲ. What evidence you have to say that he should run, jump and jog, that his foot is normal? Have you taken an X-ray? Have you gone through his workup? Is he having ulcer? Is he having sharp foot? You need to assess the foot before you give any exercise advice to the patient. So we make it very clear that low risk he can have a walk of 10,000 steps. Medium risk 5,000 steps. High risk minimize the number of steps. High risk is very dangerous. We start walking. I shout at my patient. Don't walk. If you are walking, you are breaking the feet. How it breaks, I will show you. ನಾವೇನ್ ಮಾಡಬೇಕು ಸರ್? There are units available now. Sit in the house. Keep on doing this simple exercise where there is no body weight on the feet. ನಿಮ್ಮ ಕಾಲಿನ ಮೇಲೆ ನಿಮ್ಮ ದೇಹದ ಭಾರ ಇರಲೇಬಾರದು. ಆ ಎಕ್ಸರ್ಸೈಸ್ ಮಾಡಬಹುದು. This is very important. I have seen every doctor wants to do dressing by a staff who are sitting there. ನೀವೆಲ್ಲರೂ ಮಾಡ್ತೀರಾ ಡ್ರೆಸ್ಸಿಂಗ್? ಹಿಂದೆ ಕೂತವರು ಎಲ್ಲ ಪ್ಯಾರಾಮೆಡಿಕಲ್ ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡಿ ನಿಮಗೆ ಆ ಗಂಟು ಕಟ್ಟಾರ ನೋಡಮ್ಮ ಅಲ್ಲಿ ಅವ ಹ್ಯಾಂಗ್ ಗಂಟು ಹಾಕ್ಯಾರ ನೋಡಲ್ಲಿ. Look at that how it has not placed over there. Can you see? The most dangerous way of doing dressings. Never put a knot of a dressing on the plantar area or on the dorsal area. Plantar area, it increases the pressure. On dorsal area, it cuts off the pressure. Vascular flow. Simple thing. Roll of dressing in DFUs. Dressing heals the wound. Patient dressing ಆರಾಮಾಗ್ತದೆ. If that would have been case, why so many patients are getting admitted? In every medical college, 25% of the surgical beds are occupied by diabetic foot. Dressing ಆರಾಮಾಗ್ತದಲ್ಲ? No. Properly selected dressing enhances the body's ability to heal the wound. Please understand. Dressings don't heal the wound. ಸರ್ ಹೆಂಗದ ಮ್ಯಾನೇಜ್ ಮಾಡ್ಬೇಕು ನಾವು ಹಂಗಿದ್ರೆ? HbO2 ಹೈಪರ್ಬಾರಿಕ್ ಕಳ್ಸ್ಬೇಕನ್ರಿ? ವ್ಯಾಕ್ ಮಾಡ್ಬೇಕನ್ರಿ? Look at knowledge. They don't want to apply clinical. What I'm supposed to do? Normal saline is what evidence based up till now. That is the best remedy. Daily high soakage is there. You can do it twice a day. See that wound bed is prepared well. Can you see how beautiful everything has been in 100 days? So what I'm supposed to do? I'll show you. I have brought the plaster. TCC hang ಹಾಕಬೇಕು. ನಿಮ್ ಕ್ಲಿನಿಕ್ ನಾಗ ನೀವು TCC ಹಾಕಲಿಕ್ಕೆ ಬರ್ತೈತಿಲ್ಲ. ಹೇಳಿ ಸರ್ ಆರ್ಥೋಪೆಡಿಕ್ಸ್ ಸರ್ಜನ್ ಹೇಳ್ತೀನಿ. No, a GP can do it. I will demonstrate here. It's a very simple technique. 4 foot ಇರಲಿ, mid foot ಇರಲಿ, hill foot ಇರಲಿ. Simple TCC ಹಾಕ್ರಿ. Operation ಏನು ಬೇಡ. Everything heals well. When you can do this, why the patient is going in so many complications? I will show you a simple videos. I want you to enjoy this. Then I'll go with live workshop. How one has to do it. See, look at how the heel strikes and take off. ನಮ್ಮ ಹಿಂಬಳ ಮೊದಲು ನೆಲಕ್ಕೆ ಥಡ್ ಹೊಡಿತದೆ. That is almost around say more than 3 times of body weight. ನಾ 60 180 ಕಿಲೋ heel ಹೊಡಿತದೆ. Then take off ಏನಾಗ್ತದೆ 6 times of our body weight. That's the reason ನಿಮ್ಮ ಕಾಲಲ್ಲಿರುವಂತಹ ಸಕ್ಕರೆ ಕಾಯಿಲೆ ಎಲ್ಲ ಪೇಷಂಟ್ಗಳಿಗೆ ಮುಂಭಾಗದಲ್ಲಿ ಗಾಯಗಳಿದಾವ, ನಡಕ ಹಿಂಭಾಗ ಇಲ್ಲ, ಎಲ್ಲ ಮುಂಭಾಗದಲ್ಲಿದಾವ. Because 6 times of your body weight hits the ground. Next ಹೆಂಗ್ ಕಾಣ್ತದು? This is how it looks. How? Our Indian foot access pronation. It has access pronation. ನಮ್ದೇನ್ Asians ನಾವು ನಮ್ಮ ಹಿಂಬಳ ಹಿಟ್ಟಾದ್ಮೇಲೆ ಕಾಲು ಹಿಂಗ್ ಹೊಳ್ತದೆ. It pronates excessively. That's the reason we have a maximum steps there. ಈಗ ನಿಮ್ಗೆ ತೋರಿಸ್ಬಿಡ್ತೀನಿ ಇದೊಂದು ಚಪ್ಪಲಿ ನೋಡ್ಬೇಕು ದಿವಸ. ಈಗ ನಮ್ಮ ಹುಡುಗರೆಲ್ಲ ಬಂದಾರಲ್ಲ ಸ್ಟಾಫ್ ಅವ್ರ ಕೆಲಸ ಕಾಲಿನ ಫೋಟೋ ಕಳ್ಸೋದು ನನಗೆ. Then patient comes inside. I never see the patient at all. 80 to 90% is written there. ಚಪ್ಪಲೆಗೆಲ್ಲ ಏನೇನಾಗಲಿ ಅದಕ್ಕೆ ಹೈಟೆಕ್ ಗೆಜೆಟ್ ಬೇಡ. Look at ನೋಡ್ರಿ ಗ್ರೇಟ್ ಟು ಮ್ಯಾಕ್ಸಿಮಮ್ ಪ್ರೆಷರ್ ಆಗಿದೆ. ಆಲ್ ಸೆಂಟ್ರಲ್ ಪಾರ್ಟ್ಸ್ ಹಿಂಬಳೆಲ್ಲ ಹೋಗಿದೆ. ಅದಕ್ಕೆ ಇಲ್ಲಿ ಟೆಸ್ಟ್ ಮಾಡಕ್ಕೆ ಬೆಂಗಳೂರಿಗೆ ಹೋಗಬೇಕು, ಬಾಂಬೆಗೆ ಹೋಗಬೇಕು. No, there is no need. Everything is there. In the footwear. Footwear is a new science. If there is a pressure there, you offload the pressure and everything does well. Insole change ಮಾಡಿ. ಇದನ್ನು ಕೂಡ hesitate nail cutting. This is called nail cutter. Nail trimmer. ನೀವು ಮನೆಯಲ್ಲಿ nail cutter ತೆಗಿಲಿಕ್ಕೆ. You have to have this kind of instrument which can take care of the nail cut. Simple nail cutting. Go across. Don't get inside. Common callus ದಪ್ಪ ಚರ್ಮ ಅದನ್ನು ತೆಗಿಬೇಕು. Keep your blade parallel and just keep on shaving the thin callus. See that? I don't know. Your videos are not working, dear. IT segment not working in the right way. Simple technique. Keep the blade in a parallel callus and keep on piece by piece shaving it. Don't think of going in a one piece. ಸಣ್ಣ ತುಕಡಿ ತೆಗಿತಾ ಹೋಗಿ. Enough. That callus is a low. That callus is extra pressure. Shave it off and put simple dressing. Everything heals after offloading. ಸರ್ ನಮ್ಗೆ ಫಿಸಿಷಿಯನ್ ದೇವಸರ ನಮಗೆ ಬ್ಲೇಡ್ ಲೈಕ್ ಆಗೋದಿಲ್ರಿ. So I told them okay, blade like 10 number. Okay. You can use this cutter itself. You can see how comfortably you can do the workup. Physicians are very afraid of knife. They don't want to touch the knife. Get bad ಅಂತ ಹೇಳಿದ್ರು. So we developed this technique. I just want you to stand. Can you help me out? Anyway, the most popular Mandakini offloading device. If I am going to get this, yeah, you can see. ನಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಯೂಸ್ ಮಾಡಿದ ಗ್ಲೌಸ್ ಮುಗಿತು ನಾವು. We just throw them. Don't. You have to clear them. ನಾ ತೋರಿಸ್ತೀನಿ ಮಾಡಿ ನಿಮಗೆ. Simple. ಅದರೊಂದು ಡೈನಾಪ್ಲಾಸ್ಟ್ ಅದರೊಳಗೆ ಗ್ಲೌಸ್ ಹಾಕಿ ತಿರುಗಿಸಿ. ಏರ್ ಸ್ಟ್ರಾಪ್ all those paramedical stuff ಮಾಡ್ಬೋದು ನೀವು ಇದನ್ನ ಮಾಡಿ ಒಂದು ವೇಳೆ ಇಲ್ಲಿ ಅಲ್ಸರಿತ್ತಪ್ಪ ಇಲ್ಲಿಟ್ಬಿಡಿ ಅದನ್ನ fix it here it offloads that area simple mandakini offloading device everyone is using in rural area the ulcers are healing within 100 days. These are simple things which is costing only 10 rupees for the patient, which can be practiced, and it is air freely available in this world. You need not to pay for it. And you can see that this is how it is placed, and patients walking with accommodative footwear. A simplified technique can be implemented in rural areas to prevent further complications like infection. He is walking. He can have accommodative footwear. You can see this. How comfortably this is taken off, trimmed off. So all physicians can comfortably use the nail trimmer to take out the callus and you can heal and do the dressing. A big thank you. I'm going to go for a live workshop. Am I audible? Yeah. Hope I'm audible. When I do surgery, I have seen people coming from medical colleges don't have this. If anybody has surgery done, operation sir, he comes barefoot. Wrong. He has to have a shoe. Cashew is meant for accommodating huge dressings in the feet. If you are not recommending this to the patient, we are doing blunders. We are doing blunders. Already he has insensate feet. Operate wrong. Operated feet should have a cashew. Very important. Sir, ನಂದೇನು ಆಪರೇಷನ್ ಆಗಿಲ್ರಿ. ನನಗೆ ಗಾಯ ಏನೂ ಇಲ್ಲ. ಬಟ್ ನನ್ನ ನಿರೋಪತಿ ಸರ್. ಕಾಲಂಗಿ ಜಾರಿದ್ದು ಗುರುತಾಗೋದಿಲ್ಲ. ರಾತ್ರಿ ನಿದ್ದೆ ಮಾಡಕ್ಕೆ ಕೊಡೋದಿಲ್ಲ. ಕರೆಂಟ್ ಶಾಕ್ ಹೊಡೆದಂಗೆ ಆಗ್ತದೆ. ನಿದ್ದೆ ಮಾಡಕ್ಕೆ ಕೊಡೋದಿಲ್ಲ ಸರ್. ಅದಕ್ಕೆ ಏನು ಮಾಡ್ತಾರೆ ಗೊತ್ತೇನ್ರಿ? ಟೆಸ್ಟಿಂಗ್ ಮಾಡಿರ್ತಾರೆ ಎಲ್ಲರೂ. ವಾಟ್ ಯು ಹ್ಯಾವ್ ಟು ಟೆಲ್. ನಿನಗೆ ಏನಾದ್ರು ಕಾಲಿಗೆ ಬಿಸಿನೀರು ಹಾಕ್ಬೇಡ, ಉಸ್ಕಿನ ಚೀಲ ಗರಂ ಮಾಡಿಬೇಡ, ಅಯೋಡೆಕ್ಸ್ ಅಥವಾ 108 ತಿಕ್ಕಬೇಡ. ಹಳ್ಳಿಯಿಂದ ಜನ ಬರ್ತಾರೆ. ಸರ್ ಮೊಮ್ಮಗ ಇದ್ರಿ, ಕಾಲು ನುಸಾಗ ಭಾಳ ಫೆಸಿಲಿಟೀಸ್ ಆಗಿರ್ತದೆ. ದಿಸ್ ಇಸ್ ಪ್ರಾಕ್ಟೀಸ್ ವಿಲೇಜಸ್. ಮೊಮ್ಮಗ ಕಾಲು ಪಾಂಚ್ ಹೇಳ್ತಾರೆ. This I have done it to my grandfather 30-40 years. Our diabetes ಇದ್ದಿದ್ದಿಲ್ಲ. It was not there. But now it is still practice. So we recommend then gel socks, temple socks. Sir, I have told all my patients. ನಿಮ್ಮ ಮನೆಯಾಗಿ ದೇವರು ಏನೇ ಇರಲಿ, ನೀವೀಗ ಡಯಾಬಿಟಿಸ್ ಭಾರತೀಯರಲ್ಲ, ನೀವು ಅಮೆರಿಕ ಎಲ್ಲ ಕಡೆ ಶೂಸ್ ಮ್ಯಾಂಡೇಟ್ ಹಾಕೊಂಡು ಹೋಗ್ಬೇಕು. ಸರ್ ನಡೆಯಂಗಿಲ್ಲ ದೇವ್ರ ಬಾಟ್ ಹಂಗಿದ್ರೆ ₹1,000 ಮುಂದೆ ನಾವು ಹೆಸರು ಏನು ಮಾಡೋದು ಕರಿಗೆ ಮಾಡು ನಿಮಗೇನು ಮಾಡೋದಿಲ್ಲ ಬಿಕಾಸ್ ದಟ್ ಇಸ್ ಹೌ ಟು ಬಿ ಕನ್ವಿನ್ಸ್ ದೆನ್ ಓನ್ಲಿ ದೇ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ಅದರ್ವೈಸ್ ಕಲ್ಚರ್ನಲ್ಲಿ ಇಷ್ಟ ಆಗಿಬಿಟ್ಟದು ದೇ ವಿಲ್ ನೆವರ್ ಸೇ ಗುಡಿಗೆ ಹೋಗಿ ಚಪ್ಪಲಿ ಹಾಕೊಂಡು ಹೋಗಂತ ಹೇಳ್ತಿರಲ್ಲ ಗುಡಿ ಹೋಗ್ಲಿಕ್ಕೆ ಬೇಡ ಸ್ಪಾಂಜ್ ಹೋಗ್ರಿ ಸಿಲಿಕಾನ್ ಇದರಲ್ಲಿ ದಿಸ್ ಹ್ಯಾಸ್ ಟು ಬಿ ರೆಕಮೆಂಡೆಡ್ ಆಲ್ ದಿ ಪೇಷಂಟ್ಸ್ Now, I told you stratification. ಕಾಲಿಗೆ ಗಾಯಿಲ್ಲ 0 or 1 low grade. He needs such kind of footwear. This is low grade. ಇಲ್ಲಿ ಏನು ಗಾಯಿಲ್ಲ ಏನಿಲ್ಲ. Look at the thickness of the insole. 9 mm ಲೇಬೇಕು. ಎಷ್ಟು ಜನ ಕೈಯಲ್ಲಿ ಹಿಡ್ಕೊಂಡು ನೋಡಿದ್ದೀರಾ? ನನ್ನ ಪೇಷಂಟ್ ಒಂದು ಬೈಕ್ ನಾನು ನೋಡ್ತಿರಲ್ಲ. You see his footwear, that is the culprit. That is the one which is causing the damage there. ಹಿಂದಿಂದ ನೋಡ್ರಿ ಎಲ್ಲ ಓವರ್ನೋಟ್ ಆಗಿರುತ್ತೆ ಮಾರ್ಕ್ಸ್ ಇರಂಗಿಲ್ಲ ದಟ್ ಇಸ್ ಅ ಸೈನ್ ದಟ್ ಇಟ್ ಹಿಟ್ಸ್ ವೆರಿ ಬ್ಯಾಡ್ಲಿ ಅದಕ್ಕೆ ನೀವು ಹೋಗಿ ರಿಫ್ಲೆಕ್ಸ್ ನೋಡ್ಲಿಕ್ಕೆ ನೋ ನೀಡ್ ದಿಸ್ ದೇರ್ ಇಸ್ ಗಾನ್ 4 ಫುಟ್ ಇಂಪ್ರೆಷನ್ ಇರಂಗಿಲ್ಲ ಎಲ್ಲ ಹೋಗ್ಬಿಟ್ಟಿರ್ತಾವ ಧಡ್ ಅಂತ ಹೊಡಿತೀವಿ ಕೆಳಗೆ ಕಂಟ್ರೋಲ್ ಇರಂಗಿಲ್ಲ ಕಾಲಿಗೆ ಸೆಕೆಂಡ್ ಲೇಡೀಸ್ ಸರಿ ಇದು ಹಾಕೊಂಡ್ರೆ ನಮ್ಗೆ ಎಲ್ಲ ಪಾರ್ಟಿ ಅಂತ ಬರ್ತಾರೆ. Look at how ladies are looking. They have been in a trouble to design a footwear where in their parties nobody should recognize that she is diabetic. It is a must that they should go for comfort. But they are not ready now. So we are working on that. We are working how best we can deliver the goods to them. Shoes. ಎಂತ ಶೂಸ್ ಹಾಕೋಬೇಕ್ರಿ ನಾ? A shoe is a one which doesn't have seam. ಇದಕ್ಕೆ ಸೀಮ ಇಲ್ಲ. ಒಟ್ಟು ಸೀಮ್ ಇಲ್ಲ. ಡಿಸೈನ್ ಹೊಲಿಗೆ ಏನೂ ಇಲ್ಲ. ನೀವು ತಪ್ಪಿ ಕೈ ಹಾಕಿ ಹೊಲಿಗೆ ಡಿಸೈನ್ ಎಲ್ಲ ಹಿಂಗೆ ಬರೀ ಕಾಲು ಗಾಯ ಮಾಡ್ಕೊಂಡು ಬಂದಿರ್ತಾರೆ ನಮ್ಮ ಕಡೆ. ಸೊ seamless. A footwear has to be seamless. Remember. And whatever insole, it has to be always 9 mm. This is a one footwear which is having 4 foot 10 degree hind foot 10 degree. So it rocks. There is no pressure fixed at one point. Now ಸಣ್ಣಗೆ ನಮ್ಮ ತಾಯಿ ಕುದುರೆ ಮೇಲೆ ಕುದುರಿಸ್ತಿದ್ರು ಹಿಂಗೆ ಮಾಡ್ತಿದ್ರು. So this is a rocking foot. This is a rocker bottom shoe. So this shoe has to be given to 80% of all the neuropathy or midfoot ulcer patients on its own. Remember these things. So I have done job footwear. You can ask me later. Sir, ನನಗೆ medial arch support ಇಲ್ರಿ, collapse ಆಗಿಬಿಟ್ಟಿದ್ರಿ. Yes, we have got supports. Medial arch supports are available, silicone. You just place it in. The medial arch keeps on coming up. Can you see here? It comes up like this. So this is medial arch support. Sir, ನನಗೆ ಟೋ ಸಪ್ರೇಟರ್ ಬೇಕು. ನಾನು ಎಲ್ಲ ಬಟ್ಟಿಂಗ್ ಸಮೀಪ ಬಂದು ತಿಕ್ಕಿ ಗಾಯ ಆಗ್ಲಿಕ್ಕತ್ತವ್ರಿ. ಸೊ ಯು ಕ್ಯಾನ್ ಸಿ ಹಿಯರ್, ದಿಸ್ ಇಸ್ ದ ಟೋ ಸಪ್ರೇಟರ್. You can place it and you can see that toes are separated very well. There are varieties of it. Very simply between the toes. These are toe separators, available freely. ಇಲ್ಲ ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡ್ಕೊತ ಕುಂದ್ರೆ ಆರಾಮ ಆಗ್ತೈತೆ. ನೋ, ಇಟ್ ವಿಲ್ ನೆವರ್, ಬಿಕಾಸ್ ಇಟ್ ಡಸಂಟ್ ಅಪ್ರಿಸಿಯೇಟ್ ಎನಿ ಪೇನ್. ಐ ಎಮ್ ಎ ಪ್ರೇಯರ್ನಲ್ಲಿ 2ನೇ ಲೈನ್ ಇತ್ತು, ನಾನು ನಿಮ್ಮ ನೋವನ್ನು ನಿವಾರಿಸುತ್ತೇನೆ. ಇಲ್ಲಿ ನೋವೂ ಇಲ್ಲ. ಇಟ್ ಇಸ್ ಇನ್ಸೆನ್ಸೈಟ್ ಫೀಟ್. ಯು ಹ್ಯಾವ್ ಟು ಬಿ ಮೋರ್ ಕೇರ್ಫುಲ್ ಇನ್ ಹಿಯರ್. ಯಾ, ದೆನ್ ಐ ಹ್ಯಾವ್ ಗಾಟ್ ಒನ್ ಮೋರ್ ಜಾಬ್, ವ್ಯಾಸ್ಕ್ಯುಲರ್ ಪ್ರೋಬ್ ತಗೊಂಬಂದು. ದಿಸ್ ಈಸ್ ಕಾಸ್ಟಿಂಗ್ ಯು ಜಸ್ಟ್ 15,000 rupees. Everyone in your clinic, ನಿಮಗೆ ಒಂದು ವೇಳೆ ನೋಡ್ಲಿಕ್ಕೆ ಬೇಜಾರಾಯ್ತು, ಕೈಲಿ ಡೋರ್ಸಲ್ ಸ್ಪೆಡಿಸ್, ಪೋಸ್ಟೀರಿಯರ್ ಟಿಬಿಯಲ್, ಪಾಪ್ಲಿಟಿಯಲ್ ಬ್ಯಾಡ್ ಅನಿಸ್ತು, ಎಸ್, ಯು ಕ್ಯಾನ್ ಹ್ಯಾವ್ ದಿಸ್. ಐ ಕ್ಯಾನ್ ಶೋ ಯು ಹೌ ಬ್ಯೂಟಿಫುಲಿ ಸಿಂಪಲ್. ಜಲ್ ಕೊಡಮ್ಮ. ಇಲ್ಲ, ನರದೋಷ ಏನು ನೋಡಬೇಕು ನಾ ಹೇಳ್ತೀನಿ. ಈಗ ಫಸ್ಟ್ ನನಗೆ ಪ್ರಯಾರಿಟಿ ಬೇಕಾಗಿತ್ತು ವ್ಯಾಸ್ಕ್ಯುಲರ್. ಶೇಕ್ ಇಟ್ ವೆಲ್. ಟೇಕ್ ಲಿಟಲ್ ಬಿಟ್ ಆಫ್. Can you hold the mic? You have a mic? One more mic? Or you get, here is the mic. Dorsal studies, it can, dorsal studies. ಇಲ್ಲೈತೆ ನೋಡಮ್ಮ, ಇಲ್ಲೈತೆ ಆಕಾಶ ಕೊಡೋದು ತೆಗೆದುಕೊಡು. So my concern is, please make it a point, 15 to 20,000 investment in handheld Doppler. Every clinic should have, if they are seeing maximum diabetic patients. In days to come, it is going to be like this. ಈಗ ಹ್ಯಾಂಗೆ 25 ವರ್ಷದ ಹಿಂದೆ HIV was an acute disease. Now it is no more. It's a chronic disease. But HIV ಯಾವಾಗ ಸ್ಟಾರ್ಟ್ ಆಗಿತ್ತು 25 ವರ್ಷ ಹಿಂದೆ, ಅವಾಗ ಎಲ್ಲರೂ ಇವನಿಗೆ HIV ಇತ್ತು, ಇವನಿಗೆ HIV ಇತ್ತು, ಇವನಿಗೆ HIV ಇತ್ತು ಅಂತ ಹಿಂಗೆ ಮಾತಾಡ್ತಿದ್ರು. ಇನ್ನು ಸ್ವಲ್ಪ ದಿವಸಕ್ಕೆ, ಇನ್ನೊಂದು 10 ವರ್ಷಕ್ಕೆ, ದ ಬಾಂಬ್ ಹ್ಯಾಸ್ ಎಕ್ಸ್ಪ್ಲೋಡೆಡ್. ಇಫ್ ಸಂಬಡಿ ಇಸ್ ನಾಟ್ ಡಯಾಬಿಟಿಕ್, ನಾನು ಸಕ್ರಿಯ ಲೇ, ಅವ್ನು ಸಕ್ರಿಯ ಅಂತ ನೋಡಲಿ. ದಿಸ್ ಇಸ್ ಗೋಯಿಂಗ್ ಟು ಹ್ಯಾಪನ್ ನೌ. Everyone is diabetic. So you have to work on this area. Then only I think the complications, the morbidity can be reduced drastically. Tomorrow's talk, I am going to give you how best. I don't have anything. I am in a resource poor clinic, but still I want to save the foot. You can. You can please see to it that at 20 minutes, all the solutions in your clinic can be built up. There is no need of any high-tech gadgets to save the limb, what I have learned in the last 25 years. Now the next is, I am going to show you Mandakini offloading device, how to do it. Gloves matatu. You shift madbada. See, I have brought for you gloves. Nam sisters ivaru ella fold ಮಾಡಿಟ್ಟಾರೆ, ಅಟುಕುಲೆ ಮಾಡಿದ್ದಾರೆ. There is a simple. Now I take out this. This has been recommended in RSSDI guidelines. What to practice, how to practice. Samadhana system and Mandakini has to be practiced. Place the gloves here. Can you focus? Okay. Roll it. I forgot to get the scissors. Punch the both ends. Air is trapped here, so you can feel. This is the air cushion. Suppose you have an ulcer here, place it here. Ask the patient to walk. It heals in 60 days. I'll show you tomorrow how Mandakini can heal the wounds in 60 days. A midfoot, hindfoot, and forefoot. For everything there is an answer. I think the most important, what everyone wants to refer for TCC, total contact cast. Arun. Chair togoti idra mele makkotiyo. ಸರಿಸಿಬಿಟ್ಟಿದೆ. ಅದು ಹೇಳು ಹೇಳಿ. This is a very simple cutter which is required in your clinic once you place a TCC. ಗಾಯ ಎಲ್ಲೇ ಇರಲಿ, ಫೋರ್ಫುಟ್ನಲ್ಲಿರಲಿ, ಮಿಡ್ಫುಟ್ನಲ್ಲಿರಲಿ, ಹಿಂಡ್ಫುಟ್ನಲ್ಲಿರಲಿ, you should know how to put a TCC, what care you have to give to the bony compartments, because the feet is insensate. And don't practice putting old style Rapidur. I think he will agree with me. ಇಲ್ಲಿ ಆರ್ಥೋಪೆಡಿಷನ್ ಇದ್ದಾರೆ. ಸೊ ರ್ಯಾಪಿಡೂರು ಆ ಪೌಡ್ರ್ ತಯಾರು ಮಾಡಿ ಅದು ಗರಮ್ ಆಗಿ ಅದು ಗಾಯ ಮಾಡ್ಕೊಂಡು ಬಂದಾರೆ ಎಲ್ಲ ಪೇಷಂಟ್ ನನ್ನ ಕಡೆ. ನೆವರ್ ಯೂಸ್ ದ್ಯಾಟ್. ಯು ಹ್ಯಾವ್ ಟು ಯೂಸ್ ದಿಸ್ ಕಾಸ್ಟ್ ಓನ್ಲಿ. ಇದು ಹೀಟ್ ಆಗೋದಿಲ್ಲ. ದಿಸ್ ವಿಲ್ ನೆವರ್ ಹೀಟ್ ಅಪ್. ಬಾಪ ಚಪ್ಪಲಿ ತೆಗಿ ಮಕ್ಕೋ. ಕೀಪ್ ದಿಸ್ ಸೈಡ್. ಕಾಸ್ಟ್ರೋಲ್. Lie down. ಸ್ವಲ್ಪ. Yeah. See, I will show you a simple neuropathy test. ನಿಮ್ಮ ಕಡೆ ಪೇಷಂಟ್ ಬಂದಾನೆ, ಎಲ್ಲರೂ ನೀವು ಹಿಂಗೆ ಮಕ್ಕೊಂಡಿರ್ತಾರೆ, ನಿಮ್ಮ ಕಡೆ ಏನೂ ಇನ್ಸ್ಟ್ರೂಮೆಂಟ್ಸ್ ಇಲ್ಲ. There is no monofilament, there is no vibration perception monitor, nothing, ಏನಿಲ್ಲ. But you are very quick because you are having 200 patients waiting in the hall. ಇಷ್ಟೇ. If switch, this is a new test. Keep your toe on the great toe. Third, fifth. ಗುರುತಾಗ್ತೈತೇನಪ್ಪ ನಿನಗೆ ಮುಟ್ಟಿದ್ದು? ಗುರುತಾಗ್ತೈತೇನಪ್ಪ ಮುಟ್ಟಿದ್ದು? ಗುರುತಾಗ್ತೈತೇನೋ? ಸಿಂಪಲ್, ದಟ್ಸ್ ಇನಫ್. ಎಲ್ಲಕ್ಕಿಂತ ಮಹತ್ವದ್ದು ಪ್ಯಾಸಿವ್. ಜಸ್ಟ್ ಸಿ, ಹಿಂದೆ ಹೋಗ್ತೈತೆಯೋ ಇಲ್ಲೋ ಹೆಬ್ಬಟ್ಟು. ಡೋರ್ಸಿ ಫ್ಲೆಕ್ಷನ್ ಆಫ್ ದ ಗ್ರೇಟ್ ಟೋ ಹ್ಯಾಸ್ ಟು ಬಿ 30 ಡಿಗ್ರಿ. ಎಷ್ಟು ಮಂದಿ ಇಸ್ಕಾನ್ ಟೆಂಪಲ್ಗೆ ಹೋಗಿರಿ? ಡಾಕ್ಟರ್ಸ್ ಇಲ್ಲೇ. ಏನು ಕೃಷ್ಣ ಹಿಂಗೆ ನಿತ್ತಾನಲ್ಲ, ಹಿಂಗೆ ಮಾಡ್ಕೊಂಡು ಕೊಳೆ ಹಿಡ್ಕೊಂಡು, ಅದು 30 ಡಿಗ್ರಿ ಐತಿಲ್ಲ ನೋಡ್ರಿ. ಅದಿದ್ರೆ ಅಷ್ಟೇ ಅದು ನಾರ್ಮಲ್. ಅದು ಒಂದು ವೇಳೆ ಇದು ಗ್ರೇಟೋ ಹಿಂದೆ ಹೋಗಲಿಲ್ಲ, ದಿಸ್ ಫುಟ್ ಈಸ್ ಗೋಯಿಂಗ್ ಟು ಬ್ರೇಕ್. ಇಲ್ಲಿ ಫಸ್ಟ್ ಗಾಯ ಆಗೋದ ಕೆಲಸ ಬಂದುಬಿಟ್ಟಿರ್ತದೆ. ಇಲ್ಲಿ ದಿಸ್ ಇಸ್ ದ ಫಸ್ಟ್ ಸ್ಟೆಪ್, ಯು ಕ್ಯಾನ್ ಡೂ ಇಟ್. 1 minute ಬರೀ ಬಟ್ ಹಿಂದೆ ಹೋಗಂಗೆ ಇಲ್ಲಿದು ಡಯಾಬಿಟಿಸ್ನಾಗೆ ಗಟ್ಟಿಯಾಗಿಬಿಟ್ಟಿರ್ತದೆ. ಸೆಕೆಂಡ್, ನಾವು ಟೇಕ್ ಆಫ್ ಮಾಡಬೇಕಾದ್ರೆ ಈ ಆ್ಯಂಕಲ್ ಡೋರ್ಸಿ ಫ್ಲೆಕ್ಷನ್ ಆಗ್ಬೇಕು, ಹಿಂದಕ್ಕೆ ಹೋಗ್ಬೇಕಿದು. ಇದು ಹೋಗಲಿಲ್ಲ, ಫಿಕ್ಸ್ ಆಯಿತು, ಇಟ್ ಈಸ್ ಗೋಯಿಂಗ್ ಟು ಬ್ರೇಕ್. ಓನ್ಲಿ 2. ಅದಕ್ಕೆ ನಾನು ನಿಮ್ಗೆ ಕಳಿಸಿದ್ದೆ ಟೀಸರ್ಸ್, ಫ್ಲೈಯರ್ಸ್ನಲ್ಲಿ. ಡಾಕ್ಟರ್ ಮಲ್ಲನಗೌಡವ್ರು ಭಾಳ ಮುಂಜಾನೆ ಹೆಲ್ಪ್ ಮಾಡ್ತಿದ್ದಾರೆ ನನಗೆ. ಹಾಕ್ಲಿಕ್ಕತ್ತೀನಿ ಸರ್, ಹಾಕ್ಲಿಕ್ಕತ್ತೀನಿ ರೀ. ಏನು ಟೆಸ್ಟ್ ಮಾಡಬೇಕು? ನ್ಯೂರೋಪತಿ ನೋಡ್ಕೊತ ಕುಂದ್ರಲಿಯೋ, ಮೊಬಿಲಿಟಿ ನೋಡ್ಲಿಯೋ? ಮೊಬಿಲಿಟಿ ನೋಡ್ರಿ. ಮೊಬಿಲಿಟಿ ಒಂದು ವೇಳೆ ಹೊಂಟು ತಂದ್ರೆ ಈ ಕಾಲ ಬ್ರೇಕ್ 100% ಆಗ್ತದೆ. ಬಿಕಾಸ್ ಹೀ ಈಸ್ ಗೋಯಿಂಗ್ ಟು ವಾಕ್, ಹೀ ಈಸ್ ಗೋಯಿಂಗ್ ಟು ಬ್ರೇಕ್. As long as you are going to walk, you are going to break the feet. Now let me explain you, when you are putting TCC, shin, bony prominences, very, very important to be checked. Lateral malleolus, medial malleolus. ಈ ಕಾಲಾಗ ಏನೂ ಸೆನ್ಸೇಷನ್ ಇಲ್ಲ, ನೀವೇನು ಹೇಳ್ತೀರ ಅದು ಮಾಡ್ಕೋತೈತದು. ಅಷ್ಟು ಡ್ಯಾಮೇಜ್ ಆಗ್ಲಿಕ್ಕತ್ತದ ಅದು. ಕಾಸ್ಟ್ರೋಲ್, take the castrol. You can plan extra cushion on the shin. Shin ಮೇಲೆ ಒಂದು ಲೇಯರ್ ಫಸ್ಟ್ ಹಾಕಿಬಿಡೋದು. ಸೆಕೆಂಡ್, 2 ಮೀಡಿಯಲ್ ಲ್ಯಾಟ್ರಲ್ಗೆ ಒಂದು ಎಕ್ಸ್ಟ್ರಾ ಹಾಕಿಬಿಡೋದು. ಡಬಲ್ ಪ್ರೊಟೆಕ್ಷನ್ ಯು ಆರ್ ಗಿವನ್. Now you start rolling it from the base. In abroad, they cover even toes also. ಟೋನು ಕವರ್ ಮಾಡ್ತಾರೆ ಅವ್ರು. ನಮ್ಮಂದಿ ಸರ ಅದು ಕಪ್ಪಾದ್ರೆ ಹೆಂಗ್ರಿ, ಮತ್ತು ಒಳಗೆ ಹೆಂಗೆ ನೀವು ನೋಡಂಗಿಲ್ಲ ಬಿಡಂಗಿಲ್ಲ, ಮುಚ್ತಿರಲ್ಲ ಅದನ್ನು. There is apprehension. Patients allow ಮಾಡಂಗಿಲ್ಲ, ಮಾಡಲಿಕ್ಕಿಲ್ಲ ಇಂಡಿಯಾನಾಗೆ. So we keep it open. So we just go with this. Now question is, ಸರ್ ನಾ ಇಲ್ಲಿ ತನಕ ಹಾಕಬೇಕು, ಅಬೋವ್ ಆ್ಯಂಕಲ್ ಹಾಕಬೇಕು? ನೀವು ಅಬೋವ್ ಆ್ಯಂಕಲ್ 4 inches or just above ankle if you maintain, still the results are excellent. This is proved by evidence. Ilri sir, na ಮ್ಯಾಲ್ ತನ ನೀ ಜಾಯಿಂಟ್ ತನ ಹೋಗ್ತೀನಿ, patients are very uncomfortable. So we have stopped practicing going high up. So we just place it above ankle. ಇದಕ್ಕೊಂದು ಸಿಂಪಲ್ ಸಲೈನ್ ಸ್ವಲ್ಪ ಹಾಕಮ್ಮ, ಸ್ವಲ್ಪ. That's it. Keep foot at 90 degree, plantigrade. There are 2 types of TCC. One is weight bearing, one is non-weight bearing. Non-weight bearing is altogether different. Weight bearing is altogether different. I have reached above ankle and this is enough for me. Patients are very comfortable and they feel very accommodative. If I reach high up, they say, no, I am not comfortable at all. So they try to avoid coming to me if I do it high up. I am going to have a look at a footwear of one of a doctor who is diabetic here, so that I can just tell them what exactly shoe he is wearing, what exactly is happening in his feet. I am going to demonstrate that. After doing this, just place it 90 degree. Hold it for few minutes. It hardens in 10-15 minutes. the job is done. Then what I do, I cut it laterally like this. I create two pieces, posterior slab, anterior slab. Every time, do dressing, place it, crepe bandage. That's it. This has been practiced by my patients since past so many years, and they have not gone for any high-tech shoes or high-tech some kind of a material where they say, ಇದನ್ನು ಹಾಕ್ಕೊಂಡ್ರೆ ಆರಾಮಾಗ್ತದೆ, ಇದನ್ನು ಹಾಕ್ಕೊಂಡ್ರೆ ಆರಾಮಾಗ್ತದೆ, ಈ ಮಷಿನ್ ಮೇಲೆ ಓಡಿದ್ರೆ ಹಿಂಗಾಗ್ತದೆ, ಅಲ್ಲಿ ಪ್ರೆಷರ್ ಅದು. No, nothing is required. Fix 26 bones, 52 joints. Fix them. Don't allow any joint to move anywhere. And everything settles there itself. There will be no pressure at any level. Everything settles and there is offloading. TCC is a gold standard. It's a gold standard for healing of all diabetic foot, which was designed for leprosy. Which was designed for leprosy, and whatever knowledge we have gained in diabetic foot, it has come from leprosy to metabolic now. This is a new disease which has led to peripheral neuropathy, ending up with Charcot, fracture of the bones, as well as ulcers. So now this can be cut into two pieces. ಎಷ್ಟೋ ಸಲ ನಮ್ಮ ಮಷಿನ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ ಕೂಡಲೇ ಆ ಪೇಷಂಟ್ ಹೇಳ್ತಾರೆ, ಸರ ಕಾಲು ಕಟ್ ಮಾಡಾಕತ್ತೀರೇನ್ರಿ, ಬಿಕಾಸ್ ದಟ್ ಇಸ್ ವಾಟ್ ಎವರ್ ಸೌಂಡ್ ಇಟ್ ಕ್ರಿಯೇಟ್ಸ್. And all of you know that it is not chakra. Vishnu kayagin chakra alladhu, hinge tirgangiಲ್ಲ. It just has a vibration like this. It just vibrates and it cuts that area. Because I don't have time, I have not allowed it to set in. ಬಿಚ್ಚಿಬಿಡು, ತೆಗೆದುಬಿಡು. Once you open it up, you have got two pieces, anterior slab, posterior slab. This you can use it for 100 days. The entire ulcer heals. ಒಂದು ಇದನ್ನು 3 ತಿಂಗಳು ನೀವು ಯೂಸ್ ಮಾಡ್ಬೋದು. ಯಾವಾಗ ಲಕ್ಷಣ ಹೇಳ್ರಿ. Now, the most important thing I want to tell you. Come on, thank you. Get up. If ಇಷ್ಟೆಲ್ಲ ನಾ ಮಾಡ್ಲಿಕ್ಕೆ ಆದರೂ ಗಾಯ ಮಾಡಬಹುದು, ಎಸ್, then you refer me. This is the SOP, standard of care. This standard of care, you are not doing it, and you want, ಅಲ್ಲಿ ಹುಬ್ಳಿಗೆ ಹೋಗ್ಬಿಡ, ಕರಿ ಅದರ ಕಾರಣ ಹುಡ್ಕೋತಿರ್ತಾನೆ, ಹೋಗ್ಬಿಡಲೆ. No, I don't want. I have already enough load. You can't imagine. Can you imagine? I started my practice in 1999 when first I came with CS Patil sir to Chandappa sir had called me way back 20 years back. And CS Patil sir made me to get into this field. Hardly I used to see. Hardly. ವಾರಕ್ಕೆ 3-4 ಕಾಲ್ ಬರ್ತಿದ್ದೆವು. Today I am seeing not less than 70, 80, 100. Only limb. For what? It's an inertia. Clinical inertia at certain level which has to be taken out. So then I thought, my role is not here to you. I have to reach everyone and tell them this is very simple. This is the workshop. I want you to practice this on Monday. Monday morning you should start working on this area. That kit has got everything for your patients to understand. ಒಳಗೆ ಬರುವ ಮೊದಲು ಅಲ್ಲಿ ಹೊರಗೆ ಇಟ್ಟಿದ್ದನ್ನು ಓದಿ ಬರಬೇಕು. ಆ ಎಲ್ಲ ಪೇಷಂಟ್ ಬಂದು ನೀವು ಕೇಳ್ತಾವೆ, ಸರ್ ನನ್ನ ಕಾಲಾಗ ಏನೋ ಅಂದಂಗೆ ಆಯ್ತು ನೋಡ್ರಿ ಅಂತೇಳಿ. ಇಲ್ಲ, ನಾ ಪೇಷಂಟ್ ಕೇಳಿದೆ ನಿನ್ನೆ, ಎಸ್ಟರ್ಡೇ ಓನ್ಲಿ ಒಂದು ಪೇಷಂಟ್ ಹ್ಯಾಡ್ ಕಮ್. ಅಲ್ಪ ನಿನ್ನ ಕಾಲಿಗೆ ಎಷ್ಟು ದೊಡ್ಡ ಗಾಯ ಆಗೈತಿ, ಮತ್ತು ನೀವು ಹೋಗಿ ಎಲ್ಲ ಇಂಜೆಕ್ಷನ್ ಗುಳಿಗೆ ಬರ್ಸ್ಕೊಂಡು ಬಂದು ಸರ್ಗೆ ಹೇಳಕ್ಕೆ ಬರಲಿಲ್ಲ. ಸರ್ ನಾನು ಕೇಳಿಲ್ರಿ, ನಾ ಹೇಳಿಲ್ರಿ. ನಾನು ಸರ್ ಏನು ಕೇಳಿಲ್ರಿ, ನಾ ಅದಕ್ಕೆ ಹೇಳಕ್ಕೆ ಹೋಗಲಿಲ್ಲ. There were days when we started our career in medical field in 1981. Still I remember Professor H.G. Desai sir used to say, Nalgi torso, and we used to learn that. Nalgi ನೋಡ್ಬೇಕು ಮೊದಲು ನಾವು ಪೇಷಂಟ್. That has gone now. ಕಾಲು ತೋರಿಸು ಮೊದಲು, ಆಮೇಲೆ ನಾಲ್ಗೆ ನೋಡ್ತೀನಿ ಅನ್ಬೇಕೀಗ ನೀವು. ಫಸ್ಟ್ ನಿನ್ನ ಕಾಲು ತೋರಿಸು, ಆಮೇಲೆ ನಾಲ್ಗೆ ನೋಡ್ತೀನಿ. These are the days which have changed the practice. Any questions, please welcome. I want it should be more of an interactive. What are your difficulties? Why you are not finding footwears? Why you are unable to get the material? You say that, no sir, we are remote. No, it has reached everywhere. You need to have a mind to practice in this area. Thank you so much. I thank 91 Medicon 2025 entire team, especially Dr. Chiniwal sir, Dr. Malangoda sir, and the entire scientific Madhusudan sir. I think he had a lot of discussions with me. ಏನು ಹಚ್ಚಬೇಕ್ರಿ ಇದಕ್ಕೆ ವರ್ಕ್ಶಾಪ್ಗೆ? ಸರ್ ಐ ಸೆಡ್, ಎಲ್ಲೆಡೆ ಎಲ್ಲರಿಗೂ ಹೆಲ್ತ್ ಬೇಕು, ನನಗೆ ಕಾಲು ಬೇಕು ಎಲ್ಲರದು. ಐ ವಾಂಟ್ ದ ಲಿಮ್ ಶುಡ್ ಬಿ ವೆರಿ ಸೇಫ್. ಸೊ ಪುಟ್ ಇಟ್ ಇನ್ ದ ಸೇಮ್ ವೇ ಐ ವಾಂಟ್. ಆ್ಯಂಡ್ ಶಾರ್ಟ್ಲಿ, just now I got the message from my IT team that our app is getting ready. You have to just fill the data. ನಿಮ್ಗೇನು ತಿಳಿಲ್ಲ ಅಂತ ತಿಳ್ಕೊರಿ, ನೀವು ಕಾಲಿನ ಕೆಲವೊಂದು ಫೋಟೋಸ್ ಅದಾವೆ, ಅಷ್ಟು ಹೊಡೆದು ನನಗೆ ಕಳಿಸಿದ್ರೆ ಸಾಕು. ಐ ವಿಲ್ ಗೈಡ್ ಯು ವಾಟ್ ನೆಕ್ಸ್ಟ್ ಟು ಬಿ ಡನ್. ಸೊ ದಿಸ್ ಇಸ್ ಗೋಯಿಂಗ್ ಟು ಬಿ ಎ ನೆಕ್ಸ್ಟ್ ಎರಾ ಆಫ್ ಆ್ಯಪ್ ಎ ಮಂದಾಕಿನಿ ವಿಚ್ ವಿಲ್ ಟೇಕ್ ಎ ನೆಕ್ಸ್ಟ್ ಸ್ಟೆಪ್. ಥ್ಯಾಂಕ್ ಯು. ಎನಿ ಕ್ವಶನ್ಸ್? Any questions? Welcome. Anybody, any questions? %50 of the hall is with paramedical staff, which is to be trained, which job was given by one of our very close family friend and minister, Bomai sir had told me, Shigavnaga nammella. So I had gone to Shiggaon to train all the paramedical staff. Spirit hachlinri, betadine hachlinri, hydrogen peroxide haklinri. No. Ice cream color hakidange ಏನು ಹಾಕೋಂಗಿಲ್ಲ ಗಾಯಕ್ಕೆ. ಚೆನ್ನಾಗಿರ್ತಾಗ ನಾವು ಐಸ್ ಕ್ರೀಮ್ ತೊಗೊತಿದ್ವಿ, ಹಳದಿ, ಕೆಂಪು, ನೀಲಿ ಬಣ್ಣ ಹಂಗಾಗಿ. ದ ಡಯಾಬಿಟಿಕ್ one doesn't require spirit. It doesn't require 5% betadine. It doesn't require hydrogen peroxide. It requires simple normal saline. They are all irritants. You dilute it. No role of spirit at all. Absolutely there is no role. Yes, sir.
Sir, customized footwear, sir.
Yes.
Sir, ನೀವೇ ಮಾಡ್ತೀರಾ ಅಥವಾ ಎಲ್ಲ?
Yes, we have a comprehensive care. We do all customization. Tomorrow I'm going to show you how customization is done. I didn't keep everything here because I thought that whatever they are going to be interested in, basic clinical pulse, I just wanted to pass on to them. You do this tomorrow in your clinic. Monday morning you should start working. That is the workshop. Customization I can't bring it over here. Yes, we do it in our setup.
And in case if we want to order customized footwear, and it is turning out to be very expensive, sir. Each footwear costs more than 4,000. And is there any way that, because most of the patients in our area are poor, ಏನಾದರೂ ಮಾಡ್ಬೋದಾ ಸರ್ ಅದಕ್ಕೆ?
This I had a discussion with Dinesh Gundurao sir. Sir, give me a place. I am going to start a footwear industry which can serve to the poor. This was the discussion because footwear industry needs unique materials for diabetes, and they have increased the GSTs on certain areas. The outer sole is totally different. The leather top is totally different. The GSTs, that has led to the cost. That is increase in cost. Definitely we can bring up a low costed footwears, and we are going to plan on those areas in a bigger way. We want to reach to the rural segment.
Thank you.
Foot doesn't know in diabetes what to do. Footwear has to do the job of foot. So we are working on footwear.
Sir, other than MCR, is there any other material that has come up newly?
That is the only one MCR available since leprosy time. We are using it. MCP, Plastazote. Then we have got Poron. Any number of materials there.
Which is the best one, sir?
Poron.
Poron is the best.
Multi-layer. We use Plastazote, Evazote, Poron. 3 layers combined we use it. We use a lead ball. We just throw the lead ball on that. If it jumps back, not good. It should stay there only. That's good. It doesn't give back any kind of pressure.
Thank you, sir.
Thank you.
Excuse me, sir.
Yes.
Wonderful presentation, sir. I think even non-medical attendees also will know what is the science of foot now.
I forgot.
To that level you have educated us.
Sir, can you please, any doctor who is diabetic can come forward and show the footwear. I need to tell you live what exactly goes wrong in the foot.
Before that, sir, I'll ask you one question.
I know, but somebody voluntarily who can come up.
I could have come, but I am not diabetic.
Gloves. Anyone who is diabetic, voluntarily please come forward. I can tell you this footwear is ideal or not ideal. Gloves code.
One question, sir.
Yes, sir.
Regularly, while doing a diabetic foot dressing, we use different solutions.
Yeah.
Rightly, you said hydrogen peroxide, betadine, usal, normal saline.
Yes.
When there is some slough, when there is too much of slough, we have to debride. When minimum slough is there, can we use usal as a de-sloughing agent?
Chair code kundurlik sir ge.
Can we use usal solution as a de-sloughing agent when there is minimum slough?
Sir,
Does that have any role in that?
I personally feel if it has reached to the surgeon, nothing like sharp dissection.
Okay.
Nothing like sharp dissection. That is how work on it. I never believe on any of the chemicals, any of the solutions. We don't do at all. Kudri sir, please sit up. Yeah, please. Chair kodo, sir ge.
Hello.
The first question I asked a doctor, sir, purchase this footwear. Why you purchase this footwear? Sir, Mike, please. Please listen to all his answers. Very important. A doctor giving answers regarding his footwear, why he selected.
So these shoes are very comfortable for me and also lighter. That's why I purchased.
You are diabetic since how many years, sir?
5 years.
Do you have neuropathy, sir?
I don't know.
Sir doesn't know whether he has got neuropathy. Why you prefer to have footwear only, sir? Why can't you plan a sleeper?
Pardon?
You could have planned sleeper, beautiful, some kind of a sneakers, loafers, something like that. Or you opted for this only? What was the reason like? You had any experience? Slippers were slipping off from your feet, something like that? No. How you selected in the shoe shop that this footwear is ideal for your foot?
It is somebody from my family, they will going to...
No. They came, they took your measurement.
Yeah.
Sir, Nankalo, hut number 987. So he brought it from the rack.
Yes.
And he placed it. Am I right?
Yeah.
Please take out the foot. So everyone does same thing. Nan call number ಎಷ್ಟು ನೋಡ್ರಿ ಅದರ ಪ್ರಕಾರ ನಾನು ಹಾಕೋತೀನಿ ಅಂತ. See now. This is the footwear what sir has selected. Sir, number is sir. Adidas number. Your footwear size is 7'6". Sir, insole ತೆಗೆದು ನೋಡಿಲ್ಲ ಇಲ್ಲಿ ತರ. ಈ insole thickness not even 2 mm. But Adidas. This is Adidas. This is how people get worried. Now, when you are selecting a footwear, always remember, take out the insole and place it here. Sir is having left, I have removed. Place on this. Can you focus? Nan little toe jagane illadake. Horaga ಕೂತು ನೋಡ್ರಿ, please focus there. Little toe, ಅದಕ್ಕೆ comfort ಇಲ್ಲ. Can you see? Selection of a footwear in any of the foot shop, you ಒಳಗೆ ಹಾಕಿಬಿಡ್ರಿ ಕಾಲ, ಅದ್ರ ಮೇಲೆ ಕಾಲಿಡ್ರಿ ಮೊದಲು. ಆ ಹೆಬ್ಬಟ್ಟು ಹ್ಯಾಂಗರ್ ಮಾಡಿ ಒಳಗೆ ಹೋಗ್ತೈತದೆ, ಆ ಸಣ್ಣ ಬಟ್ಟಿಗೆ ಮೇಲೆ ಬೀಸ್ ಕುಂದಿರ್ತೈತೆ ಹಿಂಗೆ ಡಾಕ್ ಅಂತ ಹೇಳಿ. ಆ್ಯಂಡ್ ದಟ್ ಈಸ್ ಅ ಕಲ್ಪ್ರಿಟ್. ಅದಕ್ಕೆ ಮತ್ತೆ ಗ್ಯಾಂಗ್ರೀನ್ ಮಾಡಿ ಬರ್ತಾರೆ ನಮ್ಮ ಕಡೆ. ಇನ್ ಡಯಾಬಿಟಿಕ್, ಪ್ಲೀಸ್ ಟೀಚ್ ಆಲ್ ಯುವರ್ ಪೇಷಂಟ್ಸ್. ಚಪ್ಪಲಿ ತೊಗೊಳಕತ್ತಿ ಸಂಜೆಗೆ ತೊಗೋಬೇಕು, ಕಾಲಿಗೆ ಸ್ವಲ್ಪ ಬಾವು ಬಂದಿರ್ತೈತಿ, ಮುಂಜಾನೆ ಮಧ್ಯಾಹ್ನ ತೊಗೊಳಂಗಿಲ್ಲ, ಈವ್ನಿಂಗ್ ಹೋಗೋದು. ಎಷ್ಟು ಅಕಾಮಡೇಟಿವ್ ಫುಟ್ವೇರ್ ಐತಿ ದಟ್ ಈಸ್ ಪಾಸಿಬಲ್ ಯು ಹ್ಯಾವ್ ಟು ಟೇಕ್. ಮುಂಜಾನೆ ತೊಗೊಂಡ್ರಿ ಕಾಲ ಸಣ್ಣದಿರ್ತೈತಿ, ಸಂಜೆಗೆ ಅಂದ್ರೆ ದೊಡ್ಡದಾಗಿರ್ತೈತಿ, ಗಾಯ ಮಾಡ್ಕೊಂಡು ಬಂದಾರೆ ನಮ್ಮ ಕಡೆ. ಸೊ ಕಾಲು ಹಿಂಗೆ ಇಡಬೇಕು, ಸಣ್ಣ ಬಟ್ಟಿಗೆ ಜಾಗ ಸಿಗಬೇಕು, ವೈಡ್ 4 ಫುಟ್ ಇರ್ಬೇಕು. That is how it should go. And insole has to be 9 mm. It has to be 9 mm. Very, very important. Otherwise, ಈಗ ನಾನು ನಿಮ್ಗೆ ತೋರಿಸ್ತೀನಿ ನೋಡಿ. Can you see the pressure of the great toe? I don't know. Whether you are able to focus? Unable to. Unable to. There is a good impression. I am counting 1, 2, 3, 4. Fifth ಇಲ್ಲ ಇಲ್ಲ. I think Chandappa sir ಅವ್ರು ಕೇಳ್ತೀನಿ ಸರ್. Fifth ಏನು ಐತೆ ನೋಡಿ impression. ಸಣ್ಣ ಇದರದು. Only 4 are there. So would you call it as an ideal footwear for your foot? When fifth toe is not having any impression at all. This is a live what doctor is going through. Look at it, what patients are going through now. Now, they are very happy with this outer sole. Very, very happy with the outer sole. My concern is, sir, you will sir, ಇದು ಸಾಫ್ಟ್ ಭಾಳ ಐತ್ರಿ ಅದಕ್ಕೆ ನಾನು ಲೈಕ್ ಆತ್ರಿ ಕ್ಯಾನ್ವಾಸ್ ರೀ ಸಾಫ್ಟ್ ಭಾಳ ಇರ್ತೈತಿ ನೆವರ್ ಗೋ ಆನ್ ದ ಟಾಪ್. Our concern is where your foot is hitting the ground. Heel strike, stance phase, take off. ಆ ಎಲ್ಲ ಫೇಸ್ನಾಗ ನಿಮ್ಗೆ ಕುಷನ್ ಬೇಕು. Outer sole is a different story. Inner sole, insole is very important. Try to understand that. Sir, I think I made my point clear to you. Don't go, Adidas is good. What you made a mistake in Adidas selection, there are 4 to 5 varieties of Adidas. What you asked him, whether you asked him for running, jogging, walking. When you say walking, always take 1 number extra. That gives, their sizes are different, our sizes are different. Put your feet on the shoe. Sir, can I have your shoe, sir? Yeah, sir is with very simple footwear. Sir, diabetic since how many years? Diabetic, ಎಷ್ಟು ವರ್ಷದಿಂದ sir? Diabetes, ಎಷ್ಟು ವರ್ಷ?
Nearly 10 years.
10 years. Anybody diabetic? 5 year, 10 year, 15 year, 25 year. I never asked their age. ವಯಸ್ಸು ಎಷ್ಟು ಅಂತ ಕೇಳಬೇಡ್ರಿ ನೀವು. 10 ವರ್ಷ ದಾಟಿದ ಮೇಲೆ. It has hit all the departments very badly. Please understand this science, which I have seen, very, very closely I have seen. Somebody says, ನನ್ನ 25 ವರ್ಷ ಆಯ್ತು ನನಗೆ ಡಯಾಬಿಟಿಸ್ ಇತ್ತು ರೀ, ನಾನು ವಯಸ್ಸು ನೀ ಹೇಳಬೇಡ, ನನ್ನ ವಯಸ್ಸಿನಿಂದ ಹೇಳಬೇಡ. Because he has already reached to end. So many complications are set in with them. So please understand that complications are very bad. Now, I avoid this. Toe ring. ಅದೇನು ಹಿಡಿತಾರಲ್ಲ, I will show you tomorrow. Footwear injuries. I always call footwear is like Cinderella. ನಾವು ಸಣ್ಣಾಗಿರ್ದಾಗ ಸಿಂಡ್ರೆಲ್ಲಾ ಸ್ಟೋರಿ ಕೇಳ್ತಿದ್ವಿ. ಶಿ ಈಸ್ ದ ಓನ್ಲಿ ಲೇಡಿ. ಒಂದು ಚಪ್ಪಲಿ ಗಡಬಡಿಯಾಗಿ ಮರೆತು ಬಂದಳು, ನಾನು ಹುಡುಕಾಡ್ಕೋದ ಅವ ಕಿಂಗ್ ಬಂದು ಆಕಿನ ಮ್ಯಾರೇಜ್ ಮಾಡ್ಕೊಂಡ. ಸಿಮಿಲರ್ಲಿ ಎ ಫುಟ್ವೇರ್ ಕ್ಯಾನ್ ಚೇಂಜ್ ಯುವರ್ ಫಾರ್ಚೂನ್. ಎಲ್ಲ ಡಯಾಬಿಟೀಸ್ ಬಂದಿದ್ದು ಫುಟ್ವೇರ್ ಕರೆಕ್ಟ್ ಹಾಕ್ಕೊಂಡ್ರಿ, ಯು ಆರ್ ಕಿಂಗ್ ಓನ್ಲಿ. ರಿಮೆಂಬರ್ ದಿಸ್. ಇದು ಟೋರ್ ರಿಂಗ್ ಒಟ್ಟೆ ಇರಬಾರ್ದು. ನೀವು ಇದನ್ನು ಹಿಡಿತೀರಿ, ಸ್ಟ್ರ್ಯಾಪ್ ಹಿಂಗೆ ಹಿಡಿದು ಎಬ್ಬಿಸ್ತೀರಿ. ಸಿ ಆಲ್ವೇಸ್ ರಿಮೆಂಬರ್, ದಿಸ್ ಈಸ್ ದ ಮೋಸ್ಟ್ ಪ್ರಾಬ್ಲಮ್ಯಾಟಿಕ್. ಯು ಗೆಟ್ hurt here. Web space nag injuries ಆಗ್ತಾವ. So avoid all such kind of footwears and see that whatever cushion he is getting, absolutely zero. There is no cushion at all. Sir, Nirupati, check ಮಾಡಿಸಿದ್ರಿ? Soft ಇರ್ಬೇಕು sir. Very important. I'll just show you. Gel socks ಕೊಡಮ್ಮ. ಸರ್ಗೆ ಹಾಕಿಸ್ಬಿಟ್ರಿ ಜೆಲ್ ಸಾಕ್ಸ್. ಹಾಕಿ ನಡಿಲಿ ಅವ್ರು ಹೇಳು. ಸರ್ ನಿಮ್ಮ ಶೂಸ್ ತೋರಿಸ್ರಿ. Yes, Skechers, one of the costly, very, very costly one, as long as Adidas, same, they run in the same space. Okay. ಹಾಕಿ ಸರಿ, ಅವ್ರಿಗೆ ಹಾಕಿ ನಡೆದು ತೋರಿಸೋರು. Look at the cushion what is given here. Just check in the 80% of the diabetic ulcers are in 4 foot. And 4 foot doesn't have cushion of even 1 mm. ಇವ್ರು ಏನು ಮಾಡ್ತಾರೆ, ಕೊಟ್ಟಿರ್ತಾರೆ ಕೈಯಾಗ ಚಪ್ಪಲಿ, ಹಿಂಗೆ ಒತ್ತಕ್ತಾರೆ, ಇಲ್ಲಿ ಹಿಂಬಳ ಕಡೆ ಒತ್ತಕ್ಕೆ ನೋಡಿ, ಭಾಳ ಸಾಫ್ಟ್ ಐತೆ, ಭಾಳ ಸಾಫ್ಟ್ ಐತೆ. ನೋ, ವಿ ವಾಂಟ್ ಸೇಮ್ 9 mm ಡೌನ್ ಅಪ್ ಟು 4 foot. That is missed. Always purchase 1 number extra. Then only you can have such kind of workups. Sir, much same story. Can you place, ಇಲ್ಲಿ ಬರ್ರಿ sir. Will you come over here and place your foot on this so that I can show you the count. ಇದ್ರ ಮೇಲೆ ಕಾಲಿಟ್ಬಿಡಿ ಸರ್. ಎಷ್ಟು ಹಾಗೆ ಹಾಕೊಂಡು ಬನ್ನಿ ಸರ್, ನಡೀತದೆ. ಇದ್ರ ಮೇಲೆ ಕಾಲಿಡ್ರಿ ಸರ್, ನಾ ಹೇಳ್ದಂಗೆ ಬಲಗಾಲಿಡ್ರಿ. ಯಾ, ಯು ಕ್ಯಾನ್ ಹೋಲ್ಡ್ ಮೀ ಆಲ್ಸೋ. ಯಾ, ಕ್ಯಾನ್ ಯು ಸಿ how it is accommodating entire little toe? You can see there, almost abutting to the curve. That is the friction. Give space there. Breathing area has to be there. Broad forefoot is a mandatory in all diabetics. Just for sir, sugar agi. Yeah, very senior in diabetes, so you have to take utmost care. Only web spaces, avoid footwear. ನನ್ನ ಕಡೆ ಪೇಷಂಟ್ಸ್ ಬಂದು ಹೇಳ್ತಾರೆ, ಸರ್ ನಾನು ಭಾಳ ಕಾಳಜಿ ಮಾಡ್ತೀನಿ ರೀ ಕಾಲಿಂದ. ಏನು ಮಾಡ್ತೀವ? ಸಾಕ್ಸ್ ಹಾಕೊಂಡು ಅಡ್ಡಾಡ್ತೇನೆ ರೀ ಮನ್ಯಾಗ. ಸಾಕ್ಸ್ ಈಸ್ ನಾಟ್ ಎ ಪ್ರೊಟೆಕ್ಷನ್ ಟು ದ ಫುಟ್. ಇಟ್ ಈಸ್ ಜೆಲ್ ಸಾಕ್ಸ್ ವಿಚ್ ಈಸ್ ಅ ಪ್ರೊಟೆಕ್ಷನ್ ಟು ದ. ನೀವು ಬಂದು ಹೇಳ್ತಾರೆ ಪೇಷಂಟ್, ಸಾಕ್ಸ್ ಹಾಕೊಂಡು ಅಡ್ಡಾಡ್ತೇನೆ ಸರ್, ನನಗೆ ಏನು ತ್ರಾಸ ಆಗೋದಿಲ್ಲ. ನೋ, ಸಾಕ್ಸ್ ಈಸ್ ನಾಟ್ ಅಟ್ ಆಲ್ ಎ ಪ್ರೊಟೆಕ್ಷನ್ ಟು ದ ನ್ಯೂರೋಪಥಿಕ್ ಫೀಟ್. ಸೊ ಪ್ಲೀಸ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದೀಸ್ ಥಿಂಗ್ಸ್. Sir, you need to go for broad footwear. That is mandatory, sir. How many kilometers you walk per day, sir? How many steps per day? How many steps per day, sir? Sir, no, hidi sir ge. Just see, sir, the comfort. How are you comfortable? Comfortable. ಅದನ್ನು ನೀ ಒಂದು ಶೂಸ್ ಅವ್ರಿಗೆ ಹಾಕಿ ನೋಡು, ಫುಟ್ವೇರ್. ಸಿ, ಇಫ್ ಯು ಗಿವ್ ಎ 9 mm ಕುಷನ್ ಅಂಡರ್ ಎ ಇನ್ಸೆನ್ಸೇಟ್ ಫೀಟ್, it always feels so much of a comfort, the pain reduces drastically. And most important thing what I want to convey you is, most of the people ಫುಟ್ವೇರ್ನಲ್ಲಿ ನಾನು ನೋಡಿದ್ದು ಪ್ರಾಬ್ಲಮ್ಮು, ಔಟರ್ ಸೋಲ್ ಡೈಲಿ ಚೆಕ್ ಮಾಡ್ಬೇಕು. ನಾ ಏನೇನು ತೆಗ್ದೇನು ಹೇಳ್ತೇವೆ ನೋಡ್ರಿ, ಮುಳ್ಳು, ಮಳಿ, ಆಮೇಲೆ ನಮ್ಮ ಮನೆ ಕಡೆ ಹೊಸ ರೋಡ್ ಆಗಾಕತ್ತಿತ್ತು ರೀ, ಕಲ್ಲು, ಶಾರ್ಪ್ ಕಲ್ಲುಗಳು ಎಲ್ಲ ಸಿಕ್ಕಾವ್ರ ಒಳಗೆ ಅದಾವೆ. ಪ್ಲೀಸ್ ಸಿ ಎವ್ರಿ ಡೇ ಔಟರ್ ಸೋಲ್, ವೆರಿ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. I have been observing these things, and this is simple clinical acumen. That's it. I am spending most of my time on the footwear, on the socks, and the most important thing, ನಾ ಎಲ್ಲ ಪೇಷಂಟ್ಗೆ ಒಳಗೆ ಕರೆಸಿ ನನ್ನ ಎದುರುಗಡೆ ಚಪ್ಪಲಿ ಹಾಕು ಅಂತ ಹೇಳ್ತೀನಿ. ದಿಸ್ ವೆರಿ ಇಂಟ್ರೆಸ್ಟಿಂಗ್. ಎಷ್ಟು ಜನ ಮಾಡ್ತೀರಿ ಈ ಹಾಲ್ನಲ್ಲಿದ್ದವರು? ಡಯಾಬಿಟೀಸ್ ಪೇಷಂಟ್ ನಿಮ್ಮ ಬಂದರೆ ಕ್ಲಿನಿಕ್ನಲ್ಲಿ ಎಷ್ಟು ಜನ ನಿಮ್ಮ ಎದುರುಗಡೆ ಹಾಕಂತ ಹೇಳ್ತೀರಿ ಅವ್ರಿಗೆ? ನಾನು ತೆಗಿಸ್ತೀನಿ ಫಸ್ಟ್ ಅವ್ರಿಗೆ, ಆಮೇಲೆ ನಾನು ಎದುರುಗಡೆ ಹಾಕಿ ತೋರಿಸಂತ ಹೇಳ್ತೀನಿ. ಅವೇನು ಮಾಡ್ತಾನೆ ಗೊತ್ತಾ? ಎಡಗಾಲ ಬಲಗಾಲನಾಗ ಹಾಕ್ತಾನೆ, ಬಲಗಾಲ ಎಡಗಾಲನಾಗ ಹಾಕ್ತಾನೆ. ಇದು ನೋಡಿರಿ ನೀವು? ಪ್ಲೀಸ್ ಹ್ಯಾವ್ ಎ ಲುಕ್. ಇಟ್ ಹ್ಯಾಪನ್ಸ್ ಎವ್ರಿ ಡೇ ರೈಟ್ ಇನ್ ಫ್ರಂಟ್ ಆಫ್ ಮೀ, ಬಿಕಾಸ್ ದೇ ಡೋಂಟ್ ಅಪ್ರಿಸಿಯೇಟ್ ಎನಿಥಿಂಗ್. ರೈಟು ಗುರುಗೆ ಲೆಫ್ಟು ಗುರ್ತಾಗೋದಿಲ್ಲ. ಸೊ ಮೇಕ್ ಇಟ್ ಎ ಪಾಯಿಂಟ್, ಪ್ಲೀಸ್ ಟೆಲ್ ದೇರ್ ರಿಲೇಷನ್ಸ್, ನಿಮ್ಮ ಡ್ಯಾಡಿ ಮಮ್ಮಿಗೆ ನೀನೇ ಚಪ್ಪಲಿ ಹಾಕ್ಬೇಕು, ಇಲ್ಲ ನೋಡೋರು ಹಿಂಗೆ ಹಾಕ್ಕೊಂಡು ಗಾಯ ಮಾಡ್ಕೊಂಡು ಬರ್ತಾರೆ. ದಿಸ್ ಇಸ್ ವಾಟ್ ಈಸ್ ಹ್ಯಾಪ್ನಿಂಗ್. ದೇರ್ ಇಸ್ ಒನ್ ಮೋರ್ ಥಿಂಗ್ ವಾಟ್ ಐ ಹ್ಯಾವ್ ಲರ್ನ್. ಮ್ಯಾರೇಜ್ ಇದು ಸ್ಟಾರ್ಟ್ ಆಗ್ತದೆ ಈಗ, ಮ್ಯಾರೇಜ್ ಸೀಸನ್ ಈಗ ಇನ್ಮೇಲೆ. ಆ ಮ್ಯಾರೇಜ್ನಾಗೆ ಚಪ್ಪಲಿ ತೆಗೆದು ಸ್ಟೇಜ್ ಮೇಲೆ ಹೋಗೋದೊಂದು ಪದ್ಧತಿ ಅದ. ಎಲ್ಲಿ? ಸೌತ್ ಕೆನರಾ. ಸೌತ್ ಕೆನರಾ ಐ ಗೆಟ್ ಲಾಟ್ ಆಫ್ ಪೇಷಂಟ್ಸ್ ಫ್ರಮ್ ಮ್ಯಾಂಗ್ಳೂರ್, ದೆನ್ ಕುಮಠಾ, ದೆನ್ ಕುಂದಾಪುರ್. ಅಲ್ಲಿ ಒಂದು ಸ್ಟ್ರಿಕ್ಟ್ ಪ್ರಥೆ, ಕಾಲಲ್ಲಿ ಚಪ್ಪಲಿ ಇಟ್ಕೊಂಡು ಮೇಲೆ ಗಂಡ ಹೆಂಡತಿಗೆ ಆಶೀರ್ವಾದ ಮಾಡುವಂಗಿಲ್ಲ. ಚಪ್ಪಲಿ ತೆಗಿಬೇಕಾದ್ರೆ ಟೆಂಪಲ್ ಹೊರಗಡೆ ಇಡ್ತಾರೆ ಅದನ್ನು. ಟೆಂಪಲ್ ಹೊರಗಡೆ ಎಲ್ಲ ಫಂಕ್ಷನ್ಸ್ ಇರ್ತಾವೆ, ಅಲ್ಲಿ ಬಿಸಿಲು ರಣ 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 ಬಿಸಿಲು, ಆ ಬಿಸಿಲಾಗಿ ಚಪ್ಪಲಿ ಇರ್ತಾವೆ. ಆ ಪೇಷಂಟ್ ಬರ್ತಾನೆ, ಎಲ್ಲ ಕಾರ್ಯಕ್ರಮ ಊಟ ಮುಗಿಸಿ ಆ ಚಪ್ಪಲಿ ಹಾಕ್ಕೊಂಡು ಸಂಜೆಗೆ ಬಂದು ಅಂದ್ಕೊಳ್ಳೆ, ಸರ್ ಕಾಲಿಗೆ ಬೊಬ್ಬೆ ಬಂದಿದೆ, ಏನು ಮಾಡಬೇಕು? ಲುಕ್ ಆಟ್ ಇಟ್. Hot sleepers, hot footwears have led to the thermal damage because he has got a neuropathy. So you tell your patients all your footwears has to be in shadow. ಎಲ್ಲ ನೆರಳಲ್ಲೇ ಇಡಬೇಕು ಚಪ್ಪಲಿ, ಬಿಸಿಲಾಗಿ ಇಡುವಂಗೆ ಇಲ್ಲ. That is how you have to manage. A footwear can do lot of damage to the diabetic people. Thank you so much. Thank you, sir. Sir, simple, avoid ಮಾಡ್ರಿ ಚಪ್ಪಲಿನ. Go for a footwear, right footwear and right socks. You can do walking provided you go through the proper checkup of your feet. X-ray standing. X-ray has to be standing always. Never ask a radiologist to take a foot X-ray lying down on the table. Ask the diabetic to stand AP, stand lateral. Then only you will see the architecture of the bone. And if bone is collapsing, no walking. It is only swimming and static cycling. I will be telling all these details tomorrow. So broad footwear. The best company so far I am not making them as a popular, but Woodlands is the only company which doesn't have this design. Tapering design ಇಲ್ಲ ಅದರದು ಅದು ಹಿಂಗೆ ಮುಂದೆ ಬ್ರಾಡ್ ಅದ ನೀವೆಲ್ಲ ನೋಡ್ರಿ ವುಡ್ಲ್ಯಾಂಡ್ಸ್ ಕಂಪ್ನಿ ಡಿಸೈನ್ಸ್ ದೇ ಆರ್ ಆಲ್ ಬ್ರಾಡ್ ಫಾರ್ ಫುಟ್ ಯಾ ಸರ್ ಐ ಆಮ್ ಗಿವಿಂಗ್ ದ ಸೊಲ್ಯೂಷನ್ಸ್ ಟುಮಾರೋ ವಾಟ್ ಐ ಹ್ಯಾವ್ ಡನ್ ಇನ್ ಎ ರಿಸೋರ್ಸ್ ಪವರ್ ಕ್ಲಿನಿಕ್ ರೈಟ್ ವೆದರ್ ಟು ರೈಟ್ ಆಂಟಿಬಯೋಟಿಕ್ ಆರ್ ನಾಟ್ ಟು ರೈಟ್ ಇನ್ಫೆಕ್ಷನ್ ಆಗಿದೆ ಏನು ಆಂಟಿಬಯೋಟಿಕ್ ಕೊಡಬೇಕು ಯಾಕೆ ಕೊಡಬೇಕು ವಿ ನೀಡ್ ದೀಸ್ ಕ್ವಶನ್ಸ್ ಅದರ್ವೈಸ್ ಎವ್ರಿಬಡಿ ಇಸ್ ರೈಟಿಂಗ್ ಆಂಟಿಬಯೋಟಿಕ್ಸ್ ಆ್ಯಂಡ್ ವಾಟ್ ಇಸ್ ದ ಎಂಡ್ ರಿಸಲ್ಟ್ ಎಸ್ ಸರ್ ಟುಡೇ ವರ್ಕ್ಶಾಪ್ ಸರ್
You want same audience to be here
yes
tomorrow
here
also.
in the same hall.
So for the treatment purpose, he wants the audience to be here tomorrow also. Dr.
Thank
Sunil,
you so much.
Dr. Sunil, what is the role of stem cell therapy in diabetic foot?
When I am reaching to rural,
No.
you are reaching to
I'm
state way.
just asking the
See,
role of it.
stem cell therapy, there are two things. You are handling a CLTI, critical limb threatening ischemia, and vascular surgeons have said, sorry boss, I can't do anything. Every vessel is blocked. Yes, you have a role there. You can plan on it. You keep on injecting on areas where the wound is not healing. It creates neovascularization. Yes, there are studies which are proved, but no enough evidence has come. So every work has been stopped.
Hello.
So far. But there were good results, good evidences were there. Good papers have come up on stem cell therapy. When a vascular surgeon says, I can't do anything in this patient, the vessels are totally blocked. There is only collateral which is taking care of, and wound is not healing because there is excess demand, supply is reduced. So you want to increase supply, push stem cells in the local area, that creates neovascularization. This is a concept.
Sir, one more question, sir.
Thank
Last
you, sir.
question. Yes, sir. Yes, sir.
Yes, sir.
Dr. Raju. Sir, just wanted to know, are your food products available online or anything?
When we have
Yes,
made
sir.
health care everywhere, we are going to make it
Yes, sir,
available everywhere.
That will be very useful, sir.
Yes.
You can directly order online, sir. Sir.
My app is working on that.
Yes, sir. Yes, sir.
It is
Yes,
going
sir.
to have all those workers.
We're waiting for that very useful app.
We need your support.
Yes, sir. Yes, sir.
Thank you, sir.
Yeah.
Thank you for that wonderful workshop.
Thank you so
Have
much,
you-
sir.
Ma'am, have you gone through checkup? After checkup. So you don't have neuropathy. Have you gone for vasculopathy assessment? Yeah. Okay. Okay. Yeah. See, so far in the literature, fine. So far in the literature, have you seen a single paper wherein it has said patient is diabetic, there is no neuropathy, there is no vasculopathy, but a nail prick has led to excellent healing? Anywhere the paper is there? No. No, I'm telling you. That's the reason. The moment there is diabetes, please go for diabetic footwear. May not use. Because our reflexes are good. We have intact nerve supply, intact blood supply, intact immune system. What is written in textbook has been taught to us in MBBS, MS, MCH. So we are looking at diabetic foot thinking that it is normal what I have learned I am practicing. No, it is compromised foot. It has neuropathy, it has got vasculopathy, it has got immunopathy. So how can you call it a normal foot? There will not be a normal foot. So you need to work on different way. No need to. Absolutely no. Yeah, see, normal men come to me for a lower limb. Sir, ನನಗೆ ಹಿಂಬಳು ನೋಸ್ತದೆ. Heel pain, they come. They are not diabetic. They have a heel pain, plantar fasciitis. They have got multiple calluses because of the high arch feet. Yes, we recommend all these feet, all these footwears for them also. Even for normal, they have got so many problems. Yeah, plantar fasciitis you have got calluses, you have got multiple problems in normal people. Foot and ankle has come up in a big way. Everything we work on it. I showed you. Same. There are two types of cones. One is a pressure cone, one is a viral. Viral words, what you get, same thing, multiple you get it in the foot also. For that you have got different management. For this you have to trim. ಶೇವ್ ಇಟ್. ನೆವರ್ ಗೋ ವಿತ್ ಎ ಕೋನ್, ಕಟ್ ಮಾಡಿ ಅದನ್ನು ಹಿಂಗೆ ಮಾಡಿ ಹೊಲಿಗೆ ಹಾಕೋದು. ನೋ, ನೆವರ್ ಇನ್ ಡಯಾಬಿಟಿಸ್ ಡೂ ಕ್ಯಾಲಸ್ ಎಕ್ಸಿಜನ್. ನೆವರ್, nobody should do it. If you are doing it, it will never heal. Only you have to shave and trim it. That's it. Okay, ma'am? Thank you. Thank you so much.
Thank you so much, sir, for conducting such a wonderful and insightful workshop. The concepts were explained with such clarity and simplicity that even a layman who is currently suffering from a diabetic foot could easily understand the principle of your concepts. Thank you again, sir.
I request all of you to be back after lunch sharp at 2:30 because we have a wonderful workshop,
Yes.
BLS and ACLS, taught by
I hope
Dr. Yatish
minimum,
Jayanti.
Indru
Usually
I think
people
they
are
enjoyed
paying
thoroughly.
thousands together to attend these kind of workshop, and it's our great prestige to have such an amazing workshop in our conference today. So please be right there at 2:30 p.m. Thank you.
Again, I am announcing, we have displayed today's sightseeing on the screen. We will also display the persons who are going to take them for the sightseeing. And one more announcement about the certificates. Whoever all attended the ECG Made Easy
And also we would like to thank Kanasu News Gangavati for telecasting alongside. We now have the presentation of the mementos. Presentation of the mementos for our most esteemed speakers for the day, Dr. Venkatesh TK and team from Apollo Hospital, Bannerghatta Road. Okay. And then we have next for the wonderful session for the practical workshop that they've been doing to Dr. Sunil Kari from Mandakini Hospital, Hubballi. Please give a huge round of applause for such a wonderful session, for making it so interactive to the audience, and also for the goodies that he has presented today. Thank you.